We have 9 minutes to go.
I'm so nervous to be the one who will give speech.
Of everyone here, you are the most senior person with a lot of experience, with a lot of background.
Well,
I can make anyone stop.
usually I'm only a speaker, but now I'm also the head of this PSP. Make me so nervous. But I'm happy in the way that we have more almost 6,000 registry.
I
That's
also hope that
really.
I also hope that people can join also. They'll be able to join.
Yeah, I think we can only take like 1,000 participants via Zoom, but the rest will be using.
They can very well be accommodated in the YouTube. All of them will be given a certificate without every one of them will be given a certificate.
Will I get the certificate as well, Dr. Asokan?
Pardon?
Will I get the certificate as well?
Yeah.
You're joking.
You are issuing the certificate. You are issuing the certificate.
You'll be the signatory.
Yeah, it will be the signatory.
I'm just joking to make myself relax.
Already we have 240 participants joined. Huh?
Yeah, but I think they are still in the waiting room though.
Oh, yeah.
Oh, let me check. Yeah, they are still in the waiting room, not yet joined.
Oh, right.
But we can allow them in, Jennifer.
So no, maybe not now. So I just wanted to quickly check. I see Dr. Vincent Balanag here. You're connected, Dr. Balanag?
Yes, I am. Yeah.
Great. So we were just
nice.
discussing. So we were just discussing that we are missing your bio. Is it possible to send us?
You haven't received my bio. I sent it through Julia.
If you can
The
resend
email of
that,
Julia.
we'll be very grateful.
Okay.
Should we put an email address there to which Dr. Balana can send? Or you can send it to me. I'm putting my email address there.
Yes, okay.
Maria, how are you?
Hello.
Maria, you are not seen. We want to see you.
Oh, okay. I'm just changing my name tag. Just changing my name tag. So I'm not just Maria. Okay. There you go.
All right.
Been watching you.
Nice. Yeah, okay. I can see Maria now.
Hello.
Hello.
We have 5 minutes to go.
Yeah.
Oh, finally, the day has come.
Yeah, I think we should allow them in now, is it not?
Yeah.
It's 5 minutes. Jennifer, I think we should allow them in.
If you can make me and Anand the co-host, we will do that for you, sir.
Jennifer also.
I thought we are going to remove the QR code for now in our background.
I hope Jennifer.
Yes, I removed the QR code. The problem is, I think the people that joined before that is not removing it. I don't know why. Even if you turn on and off your camera.
Jennifer, have you made Gautam and Hariharan as co-host?
I cannot right now. I'm not the host because Ishan is the host to make the YouTube, and if he gives it back to me, then the YouTube switches on.
Is Mohammed connected? He can do that. Mohammed, are you there?
Yes, I'm connected, but we need to go to the
Can you
main
make them
session.
co-host the people?
Yeah, for the moment I can do it because we are in practice session.
It's important to have Gautam and Hariharan. Yesterday we had a practice, and we need to have them for the certification and other things they have to harvest.
Yeah, we will do it 5 minutes into the call if that's okay.
So what I understand is once we start the call, let everybody in, you will make them co-host. Is that correct? Can somebody confirm?
Yes.
Okay.
Ishan, he need to give us the host because I don't know how it's come that he's the host of the meeting.
Because it's setting up the YouTube channel.
Uh,
That's why he's the host. That's how it comes.
all participants are still in
This is
the.
an important thing. This is an important thing we are discussing. This coordination is important because we need to issue certificates and all.
So Ishan, you are the host in this call.
Yeah.
Is it possible for you to, once the people are let in, or maybe
Yeah.
now you can try to make some other people co-hosts?
Yeah, I can do that. Yeah. So I've heard it's Gotham needs to be the co-host.
Yeah.
Yeah. Who
Hariharan.
else? Let's share, share.
And also
the
Jennifer.
co-hosting.
And also Jennifer.
Okay.
Jennifer,
I
Gautam,
mean,
Hariharan.
okay.
Shubhan sir, Shiv here, myself as well.
Yeah, Shiv Joshi.
Okay.
So I'm
Because
joined
these-
by MA NTB initiative. You may please make me co-host as well.
My NTB initiative. So, they have been given certain jobs.
Okay. IMA NTB initiative. Is that the one, right?
Yeah, that's the one.
Yes.
That's the one.
Yes, yes.
It's not by me.
Because once we
Hariharan,
start, then I'm
are
going
you
to
a home?
Yeah,
back.
now we are there, sir. Yeah.
You are a co-host. Yeah.
Yeah,
Okay,
yeah.
great.
Gautam, kindly confirm whether you have been a host.
Yeah,
Yeah.
I'm a co-host now. Only Jennifer madam is left.
Yeah, kindly make Jennifer also a co-host.
Yeah, so I'll transfer the rights to Jennifer. She'll be the host once we.
Should
Yeah.
be fine.
Yeah.
When we start, yeah. And Dr. Rao, who had joined after, he had the right background, on the white behind him. I don't know why for the rest. For example, yeah, Mohammed Yassin also has the new background without the QR code.
Can
I guess
we
because
log out and log in again?
yeah,
I'll do
Log-
that. Yeah.
Okay.
So we all have to do, right?
if you want to take out the QR code, yes. Sorry,
Okay,
I
so
forgot.
I'm doing that now.
Sahu can be a co-host so that he need not ask anyone. He can do it right away.
Jennifer, are the attendee already joined? They are still in the waiting room though.
You want
Yes,
us to
that
close the
works.
practice
Arlene, I
session
think.
and we open to everybody?
Going out
Oh,
and coming
please
back
go
also
ahead.
works.
Please
Checking
go
if
ahead.
you can hear me.
Yes.
Yes,
You can
Dr.
hear. Okay.
I think behind Dr. Sokan is it's the old background. So Dr. Sokan, if you could also log in and log out once again, please.
Dr. Arlina as well.
Yeah, Dr. Elena as well.
Ini ada yang baru.
See, I have to open it right now. I will do it in the mid-between. Be better.
Dr.
Now only 1
Asukan
minute.
should also log in, log out, Dr. RV.
Yeah. Log out I, log out. Quick.
So it's 11 should be start.
Yeah, we're just waiting for Dr. Shokan to reconnect and Dr. Lina as well.
I have the new background.
I think we can still see the QR code for Dr. Lina.
Yeah, I don't have the new background, visual background. How do the visual new one?
Because automatically, if you
Just log out and log in again, Arlena.
Oh, to log out?
You have to leave the meeting, come back again. So then it works.
Okay.
Yes, Dr. Ashokan, you have the correct background now.
great. So we
But
can
this
let
is great.
everyone back.
6,000 plus registrations. So great.
I think we should stop this on time.
Dr. Ashokan, just let's wait for Dr. Arlina to come back because she is one of the first speakers, I think.
Jennifer, and I'm going to make you the host again, right?
Okay, yes, thank you.
Okay.
Yes,
now you have
everyone
both
is-
mics.
Perfect.
I think we start
Okay.
now.
I
Yeah.
can start. I can start the webinar. I open.
Yes.
Thank you.
The Stop TB partnership. The Stop TB partnership, Commonwealth Medical Association, the Confederation of Medical Associations of Asia, Oceania, international webinar on scientific advancements in TB care is open. Welcome. To give you the welcome and the gist of objectives of the webinar, we have Dr. Erlina Burhan, who is the board member of the private sector provider constituency of Stop TB partnership. She is from Indonesia. She is a very senior professor, academic professor, Dr. Erlina Burhan, MD, MSc, PhD, professor of respiratory medicine, Department of Pulmonology and Respiratory Medicine, University of Indonesia. And she is in the board of the Stop TB partnership. She is a member of the Guideline Development Group of WHO Treatment Guidelines on Drug-Resistant TB and a member of Board of Directors in the International Union of Tuberculosis Lung Disease, the Union. And she has contributed to over 120 publications. And she is actively engaged in cutting-edge research to optimize TB care and advance vaccine development. Over to you, Dr. Erlina.
Thank you, Dr. Asokan. Very nice introduction. Okay, honorable colleagues, distinguished guests and partners. On behalf of the Stop TB Partnership Private Sector Provider constituents, I warmly welcome to this vital webinar as an effort to end TB. The private sector is not just a partner, it is a frontline force in the fight against TB. In many high-burden countries such as India, Indonesia, China, and some other African countries, many patients come to private sector, to private clinic, to private hospital, to pharmacies. This situation makes private provider critical for early diagnosis, for treatment adherence, also for reaching missing cases. Very important. Yet, challenges remain: fragmented reporting, inconsistent quality, and limited access to public sector tools. And this situation, what our PSP Constitution exists to align private provider with the NTB agenda through at least 3 things: innovation, scaling up shorter regimen like BPAL-M for drug-resistant tuberculosis, and HPMZ for drug-sensitive TB, and other diagnostic tool. Second is integration. Integration in linking private clinic to national program for diagnosis and treatment. And next one, advocacy, ensuring private sector voices shape global policies. Today webinar with experts on TB, childhood TB, diagnostic tool, including artificial intelligence, and of course, shorter regimen. Will spotlight how we can unlock the private sector potential. Let's commit to stronger partnership, more innovative policy, equitable care. And I would like also to express my special thank you to the Common Medical Association, Professor Jalal, and the Confederation of Medical Association of Asia and Oceania. The president is Dr. Maria, and all my colleagues in Stop TB Partnership for the leadership and also for the support and participation. The time to act is now. Everyone, we can end TB. Yes, we can end TB. Invest, commit, and deliver. And please enjoy the webinar. Back to you, Dr. Askan.
Thank you so much, Dr. Yerlina. And Stop TB Partnership is an organization hosted by United Nations Office. It is established in 2001, and we have more than 2,000 partners. And this constituency for the private providers, which means practically the private doctors, private nurses, any service provider in the private sector, is quite a new one. And we have partnered with Commonwealth Medical Association and the Confederation of Medical Association of Asia Oceania. Now, representing Confederation of Medical Association of Asia Oceania is its very dynamic president from Philippines, Dr. Maria Minerva Caligmag, MD, MSc, and PhD. And she is the past president of Philippine Medical Association and the current president of Confederation of Medical Associations in Asia and Oceania. And she is a staunch advocate in the Philippines fight against tuberculosis. Over to you, Dr. Maria.
Hello, good afternoon to all. Warm greetings to all across Asia and Oceania and across the globe. As president of the Confederation of Medical Associations in Asia and Oceania, it is my distinct honor to welcome you to this crucial webinar on a cross-country discussion on updates in TB diagnosis and care. Tuberculosis is an ancient disease. It continues to challenge us with this persistent presence, affecting millions globally. It is a formidable foe, as we know, that requires our collective expertise, dedication, and of course, innovation to combat effectively. There are many ways already to diagnose and treat, and today is one of those days when we'll be here all together to actually show the world that we're doing something. With us, of course, thank you very much, Dr. Ted Herbosa, our Secretary of Health, who's been very, very active in our fight against tuberculosis. We encourage all to actively participate, raise your questions, and share your invaluable insights. Together, we can forge ahead now to a future where tuberculosis hopefully is no longer a devastating threat. So thank you for being here. Just being here is already a first step towards this endeavor. Thank you very much, and enjoy the day. Enjoy learning with us. Thank you.
Thank you, Dr. Maria. Commonwealth Medical Association represents the countries which were in the erstwhile in the British Empire, right from the eastern corner of the world to the western corner of the world. We have got many nations and the national medical associations. And heading this Commonwealth Medical Association is Professor Dr. J.A. Jayalal from the southernmost corner tip of India, the Kanyakumari district. He is a professor and HOD of surgery of the Kanyakumari Government Medical College, and he is the current president of Commonwealth Medical Association. And he was the IMA national president in 2021. And he also is the coordinator for the UNESCO chair of bioethics. And he's a very dynamic warrior in the cause of tuberculosis. Welcome, Dr. Jayalal, President of Commonwealth Medical Association.
Thank you very much, Dr. Sokan sir, for doing this innovative job. The leaders of the Stop TB Partnership, the leaders of the CMAAO, the distinguished faculties, the Mumbai's Commonwealth Medical Association is extremely delighted and feel happy that we are able to organize this program along with the stakeholders. Today, I, as a president of the Commonwealth Medical Association, represent the 50% population of the tuberculosis patients in our country. Though in population wise, the Commonwealth countries only constitute 30%, but 50%, almost 50% of the population of the tuberculosis is staying within the country of the Commonwealth. So that has challenged us, that has invoked us, that has made us to actively involve, take part with the stakeholders, participate with them, and try to bring down or mitigate this challenge of the tuberculosis. It is very hard to believe that 1.5 million people are dying with the tuberculosis every year. Looking back into the history, when 18th and 19th century or the late 18th century, 25% of the people died because of tuberculosis. The whole history of tuberculosis says almost 1 billion people have died because of tuberculosis. The efforts of the global TB network has now saved more than 75 million people. So it is a challenge in front of us to safeguard our own people from dying from tuberculosis. There are so many ways we can prevent, we can early diagnose, we can appropriately treat. There are so much of newer technology is coming in, and newer instruments are coming in for early diagnosis and technology. But who are the people going to do is mainly, it is our own doctors. And it is not that what we have studied, but it is our consciousness. It is our feeling. It is our commitment. It is our responsibility. It is our duty for every modern medical doctor to see to that we are trying to help all the stakeholders in preventing this tuberculosis resulting in the death. For that, this webinar is international webinar is organized. I am so happy. Nearly 6,000 people are there. Today, you will be enriched with the knowledge on the early diagnosis, treatment, but we believe that it is not going to stop short in your heart. It should percolate into your colleague. It should percolate into your peer pressure. It will percolate into the NMA, and it will percolate into the society and community. And we will try to reduce the stigma. We will try to make it available, the drugs to reach them. And if that is reached, I think we are happy to that. I once again take this opportunity to thank the organizers, especially Dr. Asokan, Dr. Sahu, Dr. Helena, and Minerva for taking this onerous responsibility of reaching out to our own doctors, sensitizing them, and making them ambassadors of the healthcare in the tuberculosis. I wish and hope this seminar, this webinar will bring a lot of knowledge, hand-holding, and support our own colleagues. Thank you very much for this opportunity.
Thank you, Dr. Jayalal. We have with us Dr. Dilip Banushali, the National President of Indian Medical Association, with 400,000 members under him and present in all the districts of India. And we are grateful that he permitted usage of the IMA forums to disseminate the message to the young doctors. I am a national president. Dr. Dilip Banushali is based in Hyderabad, and he has held various responsibilities in Indian Medical Association. Dr. Dilip Banushali, please.
Warm greetings from Indian Medical Association headquarters, Delhi. I'm Dr. Dilip Bhanushali. It gives me immense pleasure to participate in this webinar. I thank Professor Jayalal, Dr. Ashokan, and the other dignitaries from the Commonwealth Medical Association and the organizers of this webinar. Well, TB remains the most important killer among the infections worldwide. Despite global efforts, we have not been able to control it. The myriad presentation requirement for a long duration, for a poor compliance, non-adherence to guidelines, in some cases have all made it difficult. However, our resolve to stop TB remains firm. I am delighted to participate in this program, which deals with all aspects of TB, including the burden of the disease, diagnostic modalities, treatment aspects in adults and children, drug-resistant TB, and finally the newer developments. CMA has been working for TB elimination and reforms its commitment to collaborate as part of the Stop TB Partnership of TB Eradication. I wish the program a huge success and hope with this webinar we'll be all enriched. Thank you very much.
Thank you, President Dr. Dilip Bhanushali, sir. We move on to the opening of the sessions. May I ask in Dr. Sahu to introduce our chief guest, Dr. Theodora Javier Herbosa, Honorary Secretary, Department of Health, Government of Philippines, and he is the chair of the Stop TB Partnership Board. Dr. Sahu.
Thank you, Dr. Asokan. I am Sahu, Dr. Suvanand Sahu. I work as Deputy Executive Director in Stop TB Partnership in Geneva. I have the pleasure of welcoming and introducing Dr. Herbosa, His Excellency Dr. Teodoro Herbosa is the Honorable Secretary of Department of Health, Government of Philippines. Besides his visionary leadership that he provides in the health sector in Philippines, he wears several international hats. And we are very privileged because he is currently the chair of the Stop TB Partnership Board. And he will also chair the next World Health Assembly in Geneva as the president. So, and I must say that Dr. Herbosa is very dedicated, committed to TB, and has a great vision for his country, but also for the global progress. He was in Washington, D.C. I met him there. Sir, thank you for your commitment because you just landed in Manila from Washington, D.C. today, and you are here with us. So that shows your commitment. Over to you for the keynote address.
Thank you very much, Dr. Sao. Indeed, I arrived about 12 hours earlier this morning in Manila. And I'd like to recognize the previous speakers, Dr. Erlina Burhan, the board member of the Stop TB Partnership representing the private sector provider constituency, Dr. Minerva Kalimag, president of the Confederation of Medical Associations of Asia and Oceania, Dr. J.A. Jayalal, president of the Commonwealth Medical Association, our esteemed resource persons, the medical practitioners on this webinar, and all participants, my dear colleagues across all different time zones from Africa, Asia, and beyond, mabuhay from Quezon City in the Philippines. It is both an honor and a responsibility to virtually stand before you today. As chair of the Stop TB Board Partnership and Secretary of Health of a country that continues to grapple with TB as a public health crisis, I welcome you all to this scientific webinar on advancements in TB care. This event reminds us of the power of shared knowledge, innovation, and collaboration. My sincere appreciation goes to the Stop TB Partnership, CMAAO, and CMA for hosting this timely conversation on advancing in the fight against tuberculosis, a disease we have we are capable of defeating, yet one that continues to persist. The 2024 Global Tuberculosis Report brings us face to face with this challenge. In 2023, 10.8 million people developed tuberculosis, the highest number since global monitoring began. 1.25 million lives were lost, making TB once again the leading infectious disease killer worldwide, overtaking COVID-19. These are not just statistics. They reflect families disrupted, futures derailed, and a global health system still falling short. In the Philippines, we are working to reverse this. In 2023, we screened over 5.6 million individuals using artificial intelligence assisted chest x rays. In 2024, this surged to 8.1 million, a 234% increase. Diagnostic efforts have similarly expanded. Over 1.3 million people were tested for TB in 2024, exceeding the previous year's figures and demonstrating our growing diagnostic capacity nationwide. Case notifications have remained strong, with 546,360 TB cases reported this year, surpassing our national target and maintaining momentum from 2023. This consistency highlights not just improved detection, but also greater public trust in our health system. Treatment success for drug-sensitive TB improved significantly, rising from 78% to 92%, while we continue to address challenges in drug-resistant TB care. Preventive therapy also saw a notable increase, with over 75,600 individuals protected, a 29% increase from 2023. These achievements were made possible not just by programs or policies, but by the people behind them: healthcare workers, development partners, civil society organizations, public-private partnerships, and local leaders working together in pursuit of a common goal. We are entering a new era in TB care, one driven by science and powered by innovation. The tools now available to us are more sophisticated, more efficient, and more humane. In diagnostics, we are seeing a wave of transformative technologies: high sensitivity molecular tests, AI-powered imaging, and simplified sample collection methods that bring detection closer to patients' homes. In treatment, shorter, safer regimens are improving adherence and reducing stigma. What used to take 2 years of grueling therapy for drug-resistant TB can now, in many cases, be accomplished in under a year, with better outcomes and far less suffering. In prevention, we are embracing shorter TPT options, allowing us to protect more people without overwhelming the system or the individual. But access to technology is not enough. We must ensure that scientific breakthroughs translate into real-world impact. This means embedding them within a strong health system, training and equipping our health workers, and addressing social barriers that prevent people from seeking care. Ending TB is not just a public health goal. It is a matter of equity and justice, and this demands collective leadership from governments, implementers, researchers, advocates, and affected communities. We are also we also need global solidarity. Diseases do not recognize borders. Our response should not either. The burden of TB may fall heavily on certain countries, but its solution must be shared as a global endeavor. That includes sustaining financing, technical collaboration, and a commitment to keep TB high on the political agenda. in the private to the private practitioners on this webinar. You are at the front lines. In many countries, 60 to 70% of people with TB symptoms first seek care in the private sector. That first contact matters. It can mean the difference between early diagnosis or silent spread. We need your leadership, your active engagement in national TB programs, and your demand for better diagnostics and treatment. You are not just service providers, you are influencers and advocates. You are part of the solution. Colleagues, the theme of World TB Day last March, yes, we can end TB, commit, invest, deliver. So I ask you now, commit by integrating TB care into your everyday clinical work. Invest your time, your influence, your platforms, and deliver by turning this knowledge into action. Let this scientific webinar be a turning point. Together, let us push boundaries, rethink what is possible, and make the end of TB not just possible, but inevitable. Thank you very much. Maraming salamat to everyone.
Thank you, Your Excellency, Dr. Harbosa. That was very inspiring. You said many of the things that we will discuss today in a bit more detail. So thank you for those words. Yes, we are entering a new era with new advances, new technology, and let us discuss that. So now we move to the next segment. And this segment will discuss the diagnosis of TB. And here we will have...
Give me a minute, Dr. Sahu. I can introduce you also to the doctors here. Yeah, Dr. Swanand Sahu is the Deputy Executive Director of the Stop TB Partnership Secretariat in Geneva. He is a strong advocate for innovations in prevention and care, universal and equitable access, and people-focused work. He is a medical doctor and a public health specialist with over 2 decades of experience in TB alone. He has been with Stop TB in Geneva since 2009. Prior to Stop TB, he worked in the forefront of the battle against TB for several years in India with WHO. And he has also worked on polio eradication in India. Over to you, sir.
Thank you, Dr. Asokan. So we will have in the section of diagnosis 3 different presentations. One on screening, testing, but we will also combine that with the burden of TB, and that I will do. Then next will be the diagnosis of TB in children and including extrapulmonary TB. Then we will go into some exciting new tools which are in research in the downstream pipeline, where we will hear about the new things that are coming now, very exciting things. So then we will close the diagnosis part, then go to the treatment and so on. So I will first start. Let me share my screen. I hope it is in presentation mode. Dr. Asokan, is that visible?
Yeah, it's
visible. Okay, great. Great. So I will talk about 2 things quickly in the next few minutes. First is the burden of tuberculosis. And I put a deliberate picture there showing the burden, because we as medical professionals should feel the burden that is in our community, that is in our clinic, that is in our country. The second part of it is the one on what are the screening and diagnostic tools that are currently available for us to diagnose TB. So let me quickly go into the burden part of it. So tuberculosis is the biggest killer amongst all infections. There should be no doubt. If there is a link there I have given, it has claimed 1 billion, not million, 1 billion lives in the past 200 years. We know that it is airborne transmission. 2 billion, again, billion people infected, latently infected, 2 billion people. That's a huge number. And if you look at the annual statistics, In 2023, for which we have the latest WHO estimates, 1.25 million people died due to TB worldwide. This is more than if you combine the deaths due to HIV and malaria together. This exceeds that. 10.8 million active TB cases were there. And these cases are there in almost all countries, but 30 countries account for more than 80% of the burden. And we all know that TB has drug-resistant form. So WHO estimated that in 2023, 400,000 people developed what we call as rifampicin-resistant or multi-drug resistant TB, multi-drug being rifampicin and isoniazid. We also know, and Dr. Herbosa said that in many high-burden countries, 60 to 80% of people are seeking care in the private sector. So that's a huge burden going to the private sector. Now, let's look at the countries just quickly. On the left side, you see the top 20 countries in terms of numbers of TB cases in a year. You can see India leading, followed by Indonesia and a lot of countries in Asia there and Africa as well. On the right side are countries which are leading the top 20, which are per 100,000 population. So you can see Lesotho, Philippines, Myanmar, very high per 100,000 population rates of TB. But we must also understand that all countries have TB, including the US, Western European countries, but they have a much lower rate of TB. Now, because we are also doing this meeting with Commonwealth Medical Association, I wanted to make this point. You see here on the right side, if you take the global total and the 56 Commonwealth countries, about half of the TB is in the Commonwealth countries. And on the map, you see the darker the shade, the more TB there in terms of rate of TB. So it is concentrated in many of the countries that you are coming from. Now, the next question is, how are we moving? Are we doing better? Is TB decreasing or not? So internationally, there are sustainable development targets to be met by 2030. And these are the two indicators for TB. 90% reduction in TB deaths, 80% reduction in TB incidence rate. And baseline is 2015. You see the graph here. So far, the red line here is the target on both the graphs. The red line on the right side, you see, is a big gap. To reach that is not easy. If the trend continues that way, we will definitely not reach. So it is currently, the global progress is off track. Now, what do we need? Because the next question comes, what do we need to put the global progress on track? So this is the graph you saw, right? This is incidence per 100,000. We need some interventions, heavyweight interventions, to drag it down to this level that you see the red line there. What are these interventions? We will not have time in detail to go through that, but some broad buckets. We need to find and treat all TB. I will come to how many people we miss with TB. We don't diagnose and treat. That is not enough. We have to find them early before transmission. And I will come to that also, what is early TB. And then we have to prevent TB in the contacts of people with TB. It's a infectious disease, right? So we have contacts here. So contacts can be given TB preventive treatment, and that is something which will also be discussed in this webinar. Then nutrition in many countries, almost like 1 in 4 TB can be attributed to nutrition. So nutrition can drive down. Adequate nutrition can drive down the rates of TB. And then finally, there are vaccine candidates, which you will also see, 6 of them in clinical phase 3 trials, and they will do the final job in terms of prevention. Now, I wanted to make a point here. All providers of care, the medical profession, has to contribute in all these areas. Otherwise, we will not achieve this. Now, quickly going into what we will discuss today, we know TB has infection and TB has active disease. From uninfected, you become infected, active disease. Active disease has a symptomatic component, asymptomatic component. We can diagnose TB, treat TB, and cure TB. But if undiagnosed, it leads to death, very high mortality, 50% mortality, right? There are many things that can be done to prevent people from progressing from here to death. But I will focus now quickly on the screening and testing. What are the tools and what can be done? And then others will talk about other things. Now, I talked about we are not diagnosing everybody. So this is the data that you see, this is global data. Notifications of TB in 2023 reached 8.1 million globally, highest ever. That's good news, right? But if you look at the estimates, which is the orange line there, it is higher. We have 10.8 million. So there is a gap, and this gap is what we call as missing people with TB. We know they have TB, but they're missing from care. And it is our responsibility to get them diagnosed. And some related things, just quickly, why they are missing, many reasons. But look at this. Today, there is rapid molecular testing available. But according to WHO report globally, only 48%, less than 50% of TB diagnosed was diagnosed with rapid molecular test. If you look at the treatment coverage, 75% of TB is getting diagnosed and treated. If you look at drug-resistant TB coverage, it is even lower. More than half are not getting diagnosed and treated. So this is a big responsibility. And if you imagine the burden that I showed that the medical profession needs to carry. Now, before I get to the tools, I wanted to make this point because this may be new to many of you. TB has an asymptomatic component. People are not symptomatic, but it is documented that it's bacteriologically positive and it also transmits. So public health point of view, it is important. This is data, this graph you see data from number of prevalence survey. Each bar is a prevalence survey, and all of them showing that there was a big component in the prevalence survey which were asymptomatic. They were picked up for bacteriology because of X-ray positivity, not symptoms. So almost like 50% of TB is actually asymptomatic. But the issue is they can transmit, right? So now WHO has recognized for the first time what is called as asymptomatic TB. And there is a definition of this asymptomatic TB. And some of the things that we will talk here also is relevant to this, because unless we are able to detect them and do something about it, they will transmit and TB will not decrease. Now, I wanted to quickly jump into what are the opportunities. You saw a lot of problems and a lot of issues there, some new things about asymptomatic TB and all, but there are opportunities. We need to look around us. The computer has changed into laptop and into our wrist soon. But in the advances that have happened, very good things have happened. X-ray used to be something that you go to a big hospital, big machine, you take an appointment, do the X-ray, get the report only when the radiologist is available and gives the report. That has changed now. Now there are ultra portable X-rays weighing as big as much as a laptop that you can carry, and you can read the results through artificial intelligence. And artificial intelligence is now performing as good as, or even sometimes better than, trained radiologists. So that is the kind of tool that is now available. So there is no reason why we should not be able to screen large number of people with X-ray. In the past, sputum microscopy, AFP, was the standard of diagnosis. No longer. It is not recommended as diagnosis. It should be rapid molecular test. And there are a number of them. I will come to that. If you look at drug susceptibility testing, we used to do culture in the past on solid media, liquid media. Now there are molecular tests available. Even genetic sequencing is available, and I will come to some of them. Future is great because there are also cough apps coming up, non-sputum based tests coming up, which will be great for EPTP, extrapulmonary TB, and better molecular tests that can be applied at point of care. So on diagnosis, I try to simplify. There are various diagnostic algorithms that WHO and other technical agencies recommend. But for a person sitting in a clinic, what do you need? I think there are three big buckets. You need to suspect. To suspect that a person has TB, you may need to screen, and then you need to confirm that this is TB. And then once confirmed, before you start treatment, you need to look for additional drug resistance or comorbidity. right? So these three categories. On the first category, on suspicion, symptom is very important. So pulmonary TB has cough, fever, night sweats, weight loss. We know that. But extrapulmonary TB could be having any symptom of that organ which is affected. The signs will be dependent on the type of lung damage that has happened. Then X-ray is an excellent tool for screening. So X-ray is not a diagnostic tool, but it's an excellent tool for screening. So the asymptomatic TB that I was talking about, even in the absence of symptom, if an X-ray is done as a regular screening, some of them may be abnormal, and when you do the bacteriology, it may turn out to be TB. And we also need to remember that if we are in the clinic and people walk in with some risk factors, we need to screen them. For example, HIV, any immunocompromised status, contacts of TB patients, they need to be actively screened. Then once you screen and you suspect, then you need to confirm them, and confirmation is always through bacteriology. There are rapid molecular tests available. Two of them widely being used currently, the Gene Expert MTB RIF, Expert MTB RIF, and the TrueNat. In most of your countries, you should find either of them or maybe both of them. There are more tests also coming. These tests will tell you whether it is TB, it is not TB, and if it is TB, does it have rifampicin resistant TB or not? There are other tests that can help in diagnosis. For example, you have urine LAM test, LAM, that is recommended is in HIV positive patients in certain situations. And also there is something called sputum LAMP, LAMP, not LAMP. One is urine, LAM is urine, and this is sputum test. This is something that gives you TB, doesn't give you a rifampicin resistant or not status. So these are the common tests there. Then once you do that, you need to look for drug resistance before starting treatment. So there are several options there. It is either liquid culture or line probe assay, LPA, or what we call as moderate complexity NATs. There are several of them, BD Max, Abbott, Roche. They are big systems that can do high throughput testing, and also now genetic sequencing. What is important is you should look for at least isoniazid resistance and fluoroquinolone resistance, because then the treatment will become easier. Then you have to also look for comorbidity, especially for HIV, diabetes, undernutrition. A simple way to do that is to look at BMI, because then people can be put on some nutrition. And one point I wanted to make here is this is bacteriologically positive TB. Now, if you have to diagnose bacteriologically negative pulmonary TB, never diagnose that without a bacteriology test. Only after the bacteriology test is negative, you still suspect there are symptoms which could be due to TB, and you have ruled out other differential diagnosis, then you can come to the conclusion of bacteriologically negative TB. So this is about pulmonary TB. I will not go into the extrapulmonary TB, which will come in the next session, but just quickly wanted to mention here, the same three buckets are there when there is active screening happening. You may be associated with some program where they're going out into the community and doing a community-wide screening in a high vulnerability population, like urban slum or something. The concept remains the same, but here you do the screening independent of symptoms. You do X-rays, and any abnormal X-ray is subjected then to bacteriology. So otherwise, the rest of the things are same. So let me just quickly show you the X-ray machines that we have. There are several of them. This is just two of them that I put on this slide to just have a picture and imagine if you have not seen how it looks like. You can see there people taking X-ray in a wilderness somewhere, right? This is actual situation. So it is an X-ray machine and this film here, the plate here, and that's it. It can be carried to many places. Here you can see many different settings, even in camps, in mobile vans. There was also Jacob, who will speak to you, actually took it to the Himalayas and did the highest X-ray ever done. So basically the point is this can go anywhere. It is very low emission. X-ray. It is, and it works very well with artificial intelligence. I will not go into the details of artificial intelligence, but let me just tell you that you get a result with a score, and it will tell you whether it requires further testing for TB or not. But artificial intelligence softwares now are also able to tell many other diseases. It's a good screening tool for multi-disease screening as well. Now, the molecular tools that we have, I talked about the Expert and TrueNat. This is how they look. The left one here is the Expert. It's a cartridge. You put the sputum into this, in 2 hours you get a result. This is on the right side is TrueNat, and this has 2 machines, one for preparation and one for the PCR part. This is how the chip looks here. And this is also very easy. This advantage is this one is battery operated. You can also carry it and portable. So I wanted to end here by giving a message that 3 things are very important when you go for TB diagnosis. First is think about TB. Unless you think as a doctor that this symptom could be as a result of TB, we will miss a lot of people. So that's very important. Number 2 is screen and test. We have now excellent tools. Don't use old tools which are inaccurate. Use X-ray and rapid molecular tests. If you do not have it, ask your colleagues, your national programs, how to access it. The third is use modern tools for screening and testing. So that's it on this one, on the diagnosis. I will stop sharing. And we will go into the next presentation, and let me introduce for that so we have for TB in children and extrapulmonary TB, we have Dr. Nastiti Kaswandani. Dr. Nastiti is an academic staff member in the Child Health Department at the University of Indonesia. She works as a consultant in pediatric respirology at Cipto Mangunkusumo Hospital. I hope I'm pronouncing it correctly, in Jakarta. It is actually the biggest referral hospital in Indonesia. And she is also expert in TB. She is Dr. Nastiti has served is a member of the TB Expert National Committee at the Ministry of Health, and has had some active roles in professional organizations. She previously served as the chair of the Respirology Working Group at the Indonesian Pediatric Society, and also is now the vice president of the Indonesian College of Pediatrics. So, Dr. Nastiti, over to you.
Thank you very much, Dr. Sahu. Good morning and also good afternoon in Asia. First, I would like to introduce, I'm Nastiti, I'm pediatric pulmonologist from Jakarta, Indonesia. I would like to thank to Stop TB Partnership for putting the topic of childhood TB and also inviting me to deliver the topic. It's such a great honor for me to speak in this elegant event. So please allow me to share my screen. Is it visible now, Dr. Sahu?
Yes, please go ahead.
Okay, my talk is about diagnosis of childhood TB and also extrapulmonary TB. So briefly review, the last report showed that 1.3 million children have TB, which was 12% of all TB cases. So it is sadly that every 10 minutes, one child dies of TB. So WHO also recorded that 60% among all TB cases are extrapulmonary TB. So that until now, the burden of childhood TB is not something that we can take for granted. If we see these slides, the publication by DOT reported that 96% of child mortality related to TB was because of they did not access the TB treatment. So in fact, that childhood TB is curable, but if only the child is diagnosed as TB. So the big number of missing, including underdiagnosis TB in children, should become a big concern for all of us. Now, if every time we talk about childhood TB, then we agree that diagnosis TB in children is challenging because of the first is that unspecific signs and symptoms of childhood TB, because they are mimicking other diseases like TB. And the second is also difficulties in providing specimens, since children does not expel easily sputum like adults. And even the specimen can be obtained, the majority of childhood TB also paucibacillary, so that the positivity rate is low compared to adults. The immunodiagnostic test that can support the TB infection still become a problem because the CEST or IGRA is not always available, especially in remote area. And also about pulmonary TB, extrapulmonary TB in children is often overlooked. To get sample, to get accurate diagnosis result for extrapulmonary TB is more challenging. So because until now, there is no single test that can easily establish the diagnosis TB in children, the majority of TB diagnosis in children still need integrated multiple clinical approach. They are consisted of carefully history. The investigating any TB contact is important. And also we have to see the clinical examination, including assessing growth assessment. The most common symptoms of TB in children are coughing, prolonged fever, anorexia, weight loss, or failure to thrive. And also the bacteriological test is recommended, especially now the recommendation of expert ultra tend to increase. The chest X-ray also important, and if available, TB infection tests such as CEST and IGRA should be done. We have also do the investigation relevant for presumed extrapulmonary TB depending on the affecting site. And don't forget to do the HIV testing. In clinical setting where coughing is a lot seen in clinical practice, we have to be careful if we face children with chronic cough, because we have to investigate the pattern of cough. If the cough pattern is on and off, it's the recurrent cough, then it's related to asthma. If the cough is intensity high in the first week, but tend to decrease after time, then it is acute cough with delayed recovery. It is more to be a post-viral infectious cough or post-viral hyperactivity. So the pattern of cough that is related to TB is the cough that is non-remitting, persisting after weeks, then we think that the cough is related to tuberculosis in children. In 2022, Union has published chest X-ray atlas for diagnosis TB in children, which is very useful for clinicians in the field. The TB-related abnormalities in the chest X-ray consisted of enlarged lymph node, narrowing compression of large airways, opacification in lung tissue, miliary in lung parenchyma, cavitary, pleural or pericardial effusion, or abnormality of thoracic vertebrae. But the chest X-ray is not always that obvious. The majority, or actually most of children, shows the non-severe or the mild form of chest X-ray, like presented in the slide. That we can see that it only show the enlarged node in the hilar and perihilar. Sometimes it's difficult to see from anteroposterior projection, then we have to do the lateral photo to confirm the enlarged lymph node. So sometimes it is very difficult to distinguish only by chest X-ray. In the latest guideline, in 2022, WHO has developed 2 evidence-based treatment decision algorithm that is guide clinicians to diagnose TB in children. They are using clinical symptoms with and without chest X-ray. In the algorithm A with chest X-ray, if the sum of clinical signs and symptoms is more than 10, then you can start TB treatment. In the algorithm B without chest X-ray, if the clinical course summary of the number of sign is more than 10 score, then you can start TB treatment. But 1 year after the publication, there is a Lancet article to evaluate the algorithm. It is the meta-analysis from 13 studies, and the studies suggest that for the 2 algorithms, they found that sensitivity only around 85%, and the specificity even low, it is only 35%. Now the rapid diagnostic, the latest recommendation about rapid diagnosis TB detection also address some points for children. The first is that if the child with HIV negative presumptive TB, then you can use for expert or TrueNAT respiratory and stool sample. So it means both rather than respiratory or stool alone. That's the first recommendation. The second recommendation in children with HIV positive who are presumptive TB, then it should or it recommend to do the stool sample or respiratory sample and lipoarabinol on urine both rather than respiratory or stool sample alone. Another recommendation is the Mycobacterium tuberculosis antigen-based skin test like DIA-skin test or CyTB may be used for test TB infection. You know that MTB antigen-based skin test has some benefit because it combines the advantages of TST, who is simple methods by skin test, and also gathering the benefit of antigen-based, that is CEST6 and IGRA, who has high specificity. Now the next topic I want to cover is about extrapulmonary tuberculosis. We know that the proportion of extrapulmonary tuberculosis in children compared to adults is higher, and some severe form of extrapulmonary TB, such as meningitis, miliary, or abdominal TB, show the high mortality, especially in children. The sum and sign on symptoms extrapulmonary TB similar to pulmonary TB, such as the history of TB contact or constitutional or systemic symptoms such as fever, decreased body weight, or malaise. But the symptoms of EPTB vary is a wide range of presentation from non-specific like acid test, pleural effusion, or organ system specific. You cannot miss the scrophaloderma or gibbous because it's very typical appearance. And the important or the most crucial thing about EPTB that we do the effort to collect the specimen from affected site like CSF, lymph node biopsy, pleural, peritoneal, pericardial, or urine for bacteriological confirmation, including expert and also histopathology if appropriate and available. We also have to collect respiratory samples such as sputum, gastric aspirate, or stool because child may have both pulmonary and extrapulmonary TB. And chest X-ray and other imaging depending on the affected site, and don't forget to do also the HIV testing. So this table shows the clinical presentation and investigation of the most common severe form of EPTB in primary setting. This is from desk guide by IUATLD. So it is not possible to go into detail about all EPTB due to the time constraint, but there are some important points that I want to highlight. The first is about TB adenitis. If the location of TB adenitis in axilla at the same site of BCG, then we should consider BCG lymphadenitis and aware of BCG dissemination because the child may be immunocompromised but still undetected. And for severe disseminated TB in under 5, the lumbar puncture for meningitis and also chest X-ray to detect chest X-ray miliary TB is also very important. Another type of EPTB that usually in above 5 years is abdominal TB, spinal TB, pericarditis, also TB bone and joint. Usually it is seen in older children. The most challenging diagnosis, in my opinion, in my experience, is abdominal TB because we have to do the invasive procedure to obtain the sample, and the differential diagnosis of abdominal TB is too many. So we have to careful to establish the diagnosis of abdominal TB. Please allow me to share data of extrapulmonary TB in our hospital. In our hospital, for the report of 6 years, we found 48% of all cases TB are extrapulmonary TB. So the number is quite high because our hospital is tertiary hospital. So it is also reflected because the osteoarticular TB and the CNS TB is also huge number. Totally from the patient, we have 5.6 patient who is HIV positive and 8.6% had immunocompromised condition other than HIV. The majority of immunocompromised condition are malignancies, chronic kidney disease, and autoimmune disorder. From the hospital, we do the bacteriological confirmation, which is positive in almost 12% patient, and also it is 6.5% from tissue and other body fluid. From histological confirmation, which is consistent to TB, is around 27% from all cases. So providing the specimen for histopathology and also for bacteriological confirmation also challenging in extrapulmonary TB. So for the take-home message, the diagnosis TB in children still largely relies on combination of clinical signs, symptoms, radiology, bacteriological tests whenever possible, and also we have to collect the specimen, not only respiratory, but also stool whenever possible. The two evidence-based treatment decision algorithm, using or not using chest X-ray, can increase treatment access, but the data show that only reach sensitivity of 85% and the specificity low is 30%. Extrapulmonary TB is often overlooked. Obtaining the appropriate specimen from affected site for bacterial confirmation is crucial. And the future direction, we need the more data, more evidence about oral specimen for diagnosis TB in children, and also computer-aided detection program is very promising for us to increase the diagnosis TB in children. Thank you very much for your attention. Have a good day.
Thank you, Dr. Nastiti. That was very a good summary of childhood TB as well as extrapulmonary TB. And we all know that it is something that is not very easy to diagnose, TB in children and also some sites of extrapulmonary. So thank you for the very good overview of this. Next, we move to another one, which will tell us about the new developments in happening in TB diagnostics, and this will be by Dr. Jacob Creswell. Jacob Creswell is currently, he leads the innovations and grants team at Stop TB Partnership in Geneva, including the Digital Health Technology Hub and TB Reach. He describes himself as a public health researcher. He has 25 years of experience in TB and HIV program implementation, design, and evaluation. His research has focused on improving TB case detection through innovative diagnostics and innovative interventions. So, Jacob, the floor is yours. Please share your slide set. Yes, we can see it. So please go ahead.
Thank you, Sahu. Can you hear me okay?
Yes, please.
Okay. So hi, everyone. I'll talk, as Sahu mentioned, a few minutes about some of the new tools, both tools that exist right now and some of which have been mentioned, especially AI, and several new tools in the pipeline, focusing on artificial intelligence, which certainly has captured everyone's attention across health, but also in other aspects of life. As Sahu mentioned, traditional screening approaches for TB, we've looked at symptoms, people with symptoms who have prolonged cough, hemoptysis, fever, weight loss, etc. And when you suspect that someone may have TB, a sputum test is generally the test that has been ordered. For 100 years, we're using microscopy. In the last 15 years, we have tests that you can see that Dr. Sahu shared, Gene Expert platform, TrueNet platform. The results can be done in 2 hours. And they provide drug-resistant. We also know, and you've heard, that many people who have TB are asymptomatic. And you all know very well that sputum isn't an easy sample to collect. Many people who have asymptomatic TB do not complain of symptoms, can't produce sputum. And these tests are costly, and they're costly for the public sector, but they're really costly in the private sector when markups are added. And we all know that most people with TB are coming from the poorer parts of the communities where we live and work. So, has been mentioned a few times, chest X-ray has been used for decades as one of the best tools that we have for detecting TB. And while it's not specific enough to use as a diagnostic tool, which again was mentioned by Sahu, it is the most sensitive screening tool that we have. So people who don't complain of symptoms often who have TB can use chest X-ray to identify them and see abnormalities that are associated with TB on that X-ray and order a test, even if people do not complain of symptoms. It is also, of course, used to make a diagnosis, especially in children, as was just mentioned, when you have negative microbiological test results. And again, the advances in the technology have allowed the X-ray machines to be used. This is a picture from Nigeria. Secretary Urbosa mentioned all of the work that is being done in the Philippines and the millions of people that are being screened for TB in the Philippines. And it's allowed people to take the technology outside health facilities where traditionally they have been. And it's not just the moving the machines. Someone has to read those images, or something has to read those images. And now the advances in AI technology have allowed the technology to be used in more places where you don't have radiologists, you don't have expert human readers to read. And outside of many urban settings in high TB burden countries, the lack of clinicians to read X-rays expertly is apparent. So there is really clear evidence over the last 5-6 years that artificial intelligence can do as well or better than expert human radiologists. And as I said, in many places, there's not access to expert radiologists, but the technology does just as well as really world-class expert readers for TB screening, and that's important. The technology is also advancing at a really rapid rate. 7-8 years ago, it was not as good as expert human readers, and it is now, in many cases, much better. 7-8 years ago, there was only a couple products that were available, and I'll show you on the next slide. There are many more now. And there's also, I think, in general, in health, among clinical community, but also in general, in our lives, we hear a lot of concern about artificial intelligence taking jobs and taking work away from humans. And I think that while certainly there is work that changes, and that's true, that's been true for as long as we've been alive, as machines have done better, performed better. There are real advances and opportunities for the medical profession. The main one is that most people who have chest X-ray images taken, there's no the image is clean, and the AI can really reduce reader workload by identifying abnormal images for more careful reading in a triage setting, triaging those people out. The large-scale screening programs that have been mentioned, and I showed pictures of, Sahu showed pictures of, is not really where radiologists are spending their time, and so the AI is often not really taking any jobs away at that point. It's providing a service that would be very difficult for and not interesting, I think, for many radiologists. And it's also being used in background settings and in background screening in hospital settings to, again, identify images that need more chest X-ray radiographs that need more reading. At Stop TB, we've identified 23 different software developers, computer automated detection, AI detection developers with TB-specific products already on the market. And 15 of those have different certifications, many with CE marking. You can find out more about the different products that we've scouted at the website. And we are doing many evaluations of different products against each other, as well as against humans, and making those public as quickly as we can. So while this is TB and we're focused on Stop TB, and my work is really focused on tuberculosis, there is certainly limited value of AI if it's just for TB. As I said, most people who have TB, who come in and are getting X-rayed do not have TB, and often don't have significant findings on X-ray films, and the AI can reduce the workload. But it also can be used for early detection of things like lung cancer, potentially. There's been early studies of this, working on helping identifying silicosis, COPD. We do need well-designed studies that are needed, but again, with the technology improving, the processing power is improving, the data sets that are improving, there's no reason to think that that AI will be able to not it will not be able to be used beyond chest X-ray. It's already being used in many other aspects. We've seen important papers come out for breast cancer screening, for example. In ophthalmology, it's being used. So there's a lot of ways to improve that integrated care for patients. And this was a paper that was published in The Lancet last year, just thinking forward about what potentially AI could be doing in the future. Even looking at potentially chest X-ray and diabetes screening. And just here's an example. I won't read it out, but you can read it on the screen. And the ability of artificial intelligence and the ability to interpret these images and provide support to patients, but also provide support to the clinicians to help guide care. So now just a couple slides on new tests that are coming, both from in vitro diagnostics standpoint, as well as some other AI focused tests. They're unlike, again, the Expert and TrueNat over the last 10 years, really new tests. We had maybe 100 years of nothing but smear microscopy, and now we have several tests in the pipeline. There are several non-sputum tests, which are really important because of the fact that it's a hard sample to collect. You can see on the right side of the screen the Plus Life cartridge, and the left side of the screen is another oral swab test that have been developed with all of the investments that came out of COVID. And these tests can deliver results in 30 minutes or less. And as I said, just require a quick oral swab, potentially could be collected by the patient themselves. So they're much cheaper, maybe around $2 a test. So this may have real implications for especially around access to private provider systems and setups. Also, new urine-based tests, lateral flow LAM tests that you can see at the bottom of the screen, being developed by Fujifilm in Japan. As Sahu mentioned, there's only one current urine test, and it's for people with HIV. We're hopeful that with new developments in technology and improvements, you can use a urine-based test for people who are HIV negative. And there's also developments, you can see the cartridge from South Korea around new cartridge-based tests that include not just rifampicin resistance, but also isoniazid resistant testing in one cartridge. And finally, just to give you a few ideas of things that are coming down, the tests these tests, some of them will be reviewed by WHO, and we hope to have some global guidance on some of these tests as early as later this year, the next 6 to 8 months, and other tests in 2026. And then more downstream, AI is really good at image recognition, but it also can detect sounds. And one of the ways one of the things being looked at is analyzing cough sounds, and to see, maybe to detect if people are coughing, and then thinking about those sounds. Are they compatible with TB? Are there markers in the sounds that you could identify people with TB or other lung conditions? Digital stethoscopes. Early evidence is showing some promise that you can detect confirmed TB among people with general symptoms, and that again could be really important as providing when you're providing a general medical exam, using using these prompts to flag if someone might need a bacteriological test result. And you have, with all of this data that's coming in, a real ability to provide more personalized risk scores for people depending on their age, gender, their clinical history, and these things to help clinicians make, as Sahu was mentioning, really think about suspecting TB among certain groups of people. Now, you can see the picture in the top left is a rat. That's a rat that smells landmines, and you may have seen there's been a lot of news over the last few years about these rats that can smell landmines. They also can smell TB. It's probably not something that and they're trained in several countries in Africa. I've done some studies, and these rats can smell TB in sputum samples, and that's probably not something that is clinically useful. But electronic noses, again, with that are AI enabled, may be able to smell TB in samples or directly from people's breath. That's something that is being worked on. And so just to end by saying that at Stop TB, we're really engaged with many of these developers. If there is interest, please reach out to us. We're looking to engage new developers and help groups along that are interested in evaluating and testing their technology out. Thank you very much.
Thank you, Jacob. So that was a quick summary of what is going to come in diagnostics in TB. Very interesting and exciting. We are behind time by about 20 minutes, but we will try to make up. There is a break also. We will try to make up during that time. I would request speakers to be brief and stick to the time. Next, we go into from diagnosis to treatment. And treatment we will cover in two parts. The first part will be drug-susceptible TB treatment for adult children. Then we will go to drug-resistant TB treatment. So first, for drug-susceptible TB treatment, we have here Dr. Vincent Balanag. Dr. Vincent Balanag is the Executive Director of Lung Center of Philippines. He is the past president, Philippine College of Chest Physician, and past national chairman, Philippine Coalition Against TB, or PhilCat. He is also part of several research projects on TB and is a fellow of several medical professional associations. So, Dr. Balanag, the floor is yours. Please go ahead.
Good day to everyone. Can you hear me?
Yes, we can hear you.
I'll share my slide.
Not yet. Yes.
Can you see my
Can you put it on
slide?
this? Yes, very good. Go ahead, Dr. Balanag.
Okay. So good day to everyone. It's an honor and privilege to be invited to speak in this forum to represent my country, the Philippines, and my institution, the Lung Center of the Philippines. My talk will be on the treatment of drug-susceptible TB in adults and children. I will be speaking from a national perspective, but still firmly anchored on international guidelines, particularly of the World Health Organization and the Stop TB Partnership. The National TB Control Program of the Philippines is implemented by the Department of Health, and the policies on the diagnosis and treatment of TB is written in its Manual of Procedures, which is now on its 6th edition. The previous edition was crafted in 2014, and an update was deemed necessary due to the introduction of new strategies, laboratory tools, and regimens in the years that followed. New policies and procedures on TB case finding and case holding, and the shift to a patient-centered approach are the highlights of the 2021 update. The intended primary users of the Manual of Procedures are the frontline healthcare workers in the public and private sector who are directly involved in patient care, although the procedures on recording and reporting are directed mainly to facilities with TB services. In Section 3.1 of the MOP, the main policies in the treatment of drug-susceptible TB are shown. Number 1, diagnosed cases of DSTB should receive appropriate treatment, sputum collection. Number 2, standard treatment should be given based on microbiological tests available, or if not present, based on treatment history. Number 3, quality of anti-TB drugs must be ensured. Number 4, treatment response should be monitored by sputum microscopy and clinical assessment. Number 6, all adverse drug reactions should be monitored and reported. Number 7, TB patients aged 15 years or more should be provided with HIV counseling and testing. And 8, all patients 25 years or more should be screened for diabetes. In the MOP 6th edition, there are just 2 regimens recommended for adults and children with TB. Regimen 1, which is a 2-HRZE for HR, indicated for TB and extrapulmonary TB, with the exception of central nervous system and TB of the bones and joints. This is given whether there are new or retreatment cases and should be based on a result of the gene expert MTB-RIF, whether it's RIF sensitive or indeterminate. In the absence of MTB-RIF, positive sputum microscopy or TB lamp, or clinically diagnosed if MTB is negative or not done. Regimen 2, which is mainly for extrapulmonary TB, CNS bones and joints, 2-HRZE, 10-HR, again given for new or retreatment cases with the same criteria as Regimen 1. The MOP advocates the use of fixed dose formulations, with Table 1 showing dosing for adults based on weight and the number of tablets given, and Table 2 is dosing for children using fixed dose combination. In cases where fixed dose combinations are not available, which may be the situation in many health centers, the MOP also provides dosing schedules for the 4 drugs for children from 3 to 24 kilograms body weight. In the Philippines, there is another set of guidelines on TB, the Philippine Clinical Practice Guidelines for the Diagnosis and Treatment of Adult Tuberculosis, with a 2021 update. This is produced by a group of big stakeholders and spearheaded by the Philippine Coalition Against Tuberculosis, or PhilCat, the Department of Health, the University of the Philippines, Philippine General Hospital, Philippine College of Chest Physicians, and the Philippine Society of Microbiology and Infectious Disease. While the aim of the CPG was to also guide clinicians and TB personnel regarding current standards of care as regards screening, diagnosis, treatment, and prevention, it also aims to complement and harmonize with the recent Manual of Procedures, so there won't be any conflict between the 2 guidelines for both public and government workers. In the CPG, there was one main issue regarding treatment, and this is regarding rifampicin-susceptible TB cases, whether outcomes could be improved if a fluoroquinolone is added to the standard regimen for adults. The recent update considered recent medical evidence from 2015 to 2020 Thus, the recommendation is that 2-HRZE-HR, the standard regimen, remains the recommended treatment regimen, and the addition of a fluoroquinolone is not recommended. These are both statements backed by high available quality evidence. So the treatment for adults and drug-susceptible TB remains the same, but significant changes in the treatment of TB in children have been proposed in recent years. The changes were brought about by the result of the SHINE trial. This was a phase 3 randomized open-label trial comparing 4 versus 6 months in children under 16 years with severe-negative patients, non-severe TB. And this was conducted in 5 sites in Africa and India. The key findings was that 4 months of treatment was non-inferior to standard 6 months treatment in terms of unfavorable outcome. This means treatment failure, TB recurrence, deaths, and loss to follow-up. Side effects related to treatment were few and similar across both groups. The findings in the SHINE trial was incorporated in subsequent recommendations, initially as a rapid communication on updated guidelines of the management of tuberculosis in children and adolescents released in August 2021, and later in a WHO consolidated guidelines on tuberculosis released in March 2020. The recommendation seen in section 5.1 of the consolidated guideline is that in children and adolescents between 3 months and 6 months of age with non-severe suspicion or evidence of MDR-RTB, a 4-month treatment regimen 2-HRZE or 2-HR should be used. There were several remarks. Non-severe TB is defined as peripheral lymph node TB, intrathoracic lymph node TB without airway obstruction, uncomplicated TB effusion, or paucibacillary non-cavitary disease confined to one lobe of the lungs and without miliary pattern. Number 2, children who do not meet the criteria for non-severe TB should receive the standard 6-month regimen or those for severe forms of extrapulmonary TB. And number 3, the use of ethambutol in the first 2 months is recommended in settings with a high prevalence of HIV and INH resistance. A summary of WHO recommendations on drug-susceptible TB can be found in the WHO Consolidated Guidelines on Tuberculosis, Module 4. So for the first 6 months regimen, new patients with TB should receive the 6-month regimen. Optimal dosing frequency should be daily throughout the course of the therapy. The use of thrice weekly is not recommended in intensive and maintenance phase. In new PTB treatment with rifampicin-containing regimen, throughout the treatment, if a positive sputum is found on completion on intensive phase, the extension of the intensive phase is not recommended. These are based on strong or conditional evidence as seen in the slide. For the use of the 4-month regimen in drug-susceptible TB, there are 2 recommendations. People 12 years or older may receive a 4-month regimen containing isoniazid, rifampicin, moxifloxacin, and pyrazinamide, or 2-HPMZ, 2-HPM. This is a new recommendation, although this is a conditional recommendation with moderate certainty of evidence. In children and adolescents between 3 months and 16 years of age, and this I've already presented this earlier, with non-severe TB, a 4-month treatment regimen 2-HR should be used. This is also a new recommendation with strong recommendation and moderate certainty of evidence. The 4-month regimen for children has been officially adopted in the Philippines with the release of the Department Circular dated May 27, 2024. The clinical indications are in accordance with the previous WHO guidelines that the X-ray should be consistent with non-severe TB, that MTB should be negative, gene expert MTB should be negative, trace, low to very low, or with a negative sputum microscopy or a negative rapid diagnostic test, and the patient should have mild symptoms. In settings without access to X-ray, a 4-month regimen should be based, the patient should have mild symptoms, very low or trace MTB RIF results, or negative results in the smear or the other rapid diagnostic test, or they should have isolated extra thoracic or peripheral lymph nodes, whether they are confirmed by other biochemical histologic tests. However, in settings without access to X-ray or bacteriologic tests, they should not be started with a 4-month regimen. And instead, unless they are seen by an expert TB specialist in the area. Exclusions for those with a 4-month regimen, they should not be given in those with severe malnutrition, smear positive respiratory sample, MTB positive with moderate or high result, presumed or confirmed drug-resistant TB, and pregnancy. I do not know the extent of the implementation of the shorter regimen for drug-susceptible TB in children, but I came upon a news report of this implementation in the city of Manila. It goes to comment that implementing the updated guidelines, the country has made a significant move in the global effort against TB, and indeed, with a reduction in the treatment time for children, it offers better and faster recovery outcomes for children after TB. That is all. Thank you very much.
Thank you, Dr. Balanag. So that was on drug-susceptible TB. So Dr. Balanag touched upon the international guidance and also the guidelines in Manila. So wherever you are, all of your countries should have a national guideline. If you don't have, then the international one, WHO one, is on the website. But this is drug-susceptible TB. So these drugs have been there for a long time. Dr. Balanag did mention about the recent progress in shortening the treatment to 4 months in children with uncomplicated TB and in adults through this new regimen, 4-month regimen. But I must say that that regimen is not yet available. There are issues with pill burden and all, which is being sorted out, but should be available soon. So that is about the first-line treatment. Now we go to back to Professor Arlina. Professor Arlina was introduced by Dr. Ashokan in the beginning, so I will not again introduce you. But I must just say that she has a lot of passion for TB and has been moving a lot of things in Indonesia and globally also. She is quite a driver of many things. So Dr. Arlina, please, on the drug-resistant TB treatment.
Thank you, Dr. Sahu. Share my, okay. Can you see my slide?
Yes, if you can put it on the slide mode, presentation mode.
Okay. Okay, thank you. Good day, everyone, and thank you again to Stop TB Partnership for the opportunity to speak at today's webinar. I will present updates on the treatment of drug-resistant tuberculosis in adults and children. and will focus on the recent WHO guideline revision. So, tuberculosis is still remain a significant global health challenge, and according to the Global TB report in 2024, countries such as India, Russia, Indonesia report as the highest estimated burden of drug-resistant TB, and followed by China, Philippines, Pakistan, Nigeria, Bangladesh, Democratic Republic of Congo, and also Myanmar. In 2023, only 75% of reported DRT cases initiated treatment. So there were a lot of loss in the beginning. And with a global success rate only just 68%. So we see actually the gradual improvement in 2012 as shown in the left of the slide, and we are still far from the end of the TB strategy target of 90%, highlighting the need for effective intervention. So this slide show the evolution of drug-resistant TB from 2009 to the projected development in 2025. Back in 2009, the treatment regime very long, lasting 18 to 24 months or more, and involved painful injectable drug, which often led to serious side effects and, of course, poor ends. In 2015, the discovery of bedaquiline marked a turning, offering a promising alternative, and by 2017, short treatment regimen or STR of 7 months were introduced. And although they still relied on injection, but from 2019 and 2020, both long regimen and short-term regimen began to shift to fully oral option, improving and comfort and outcome. In 2022, a major breakthrough came with the introduction of novel 6-month regimen, all oral, and this is very convenient, not only for the patient, but also for the clinician and also for the system. Looking ahead of 2025, we expect to see standardized regimen that are not only shorter and injection-free, but also built of newer, more effective drug combinations such as bedaquiline, linezolid, and levofloxacin. Before 2022, patients were often treated individualized regimen, which also called long-term regimen, that could last 18 to 20 months, or shorter one, 9 to 11 months of oral regimen. However, post option came with significant issues. The number of pills per day was overwhelming, and of course led to side effect, and also some second line drugs were often very toxic. Poor adherence combined with supply chain issues further contributed to low treatment success rate, and this challenge highlighted the urgent need for more effective, more shorter, and better tolerated treatment option. So in this, I'd like to explain the key update of drug-resistant new regimen. So on April 15, 2025, WHO released update guideline recommending several shorter regimen options for drug-resistant TB. for the group of fluoroquinolone sensitive cases, BPAL-M, BPAL stands for bedaquiline, pretomanate, linezolid, and moxifloxacin, is recommended for patients aged over 14 years. And in addition to BPAL-M, there is another option for 6-month regimen, which called BDL-LFXC, B for bedaquiline, D for delamanid, L for the linezolid, and LFX for levofloxacin, and C for clofazimine. And this optional 6-month regimen is now available for use in children of any age, as well as and breastfeeding women. WHO also introduced a new modified 6-month regimen for fluoroquinolone sensitive TB, and consisting of 3 possible combinations. For those group of fluoroquinolone resistant TB, including XDR and XDR cases, FXC is also recommended. And long renal reserve, complex or severe shorter regimen are not applicable. And next, for drug-resistant TB treatment in children, children and adolescents require tailored treatment approach. For those aged over 14, the SMAN BPAL-M regimen is applicable. But to those who under 14 years old, there is an alternative such as there is alternative regimen such as bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine, or BDLFXE, and other 6-month combination are also available. And then the modified 9-month regimen discussed earlier may also be used. However, a critical component in pediatric TB care is also another issue, such as nutrition. As nutrition will worsen outcome, therefore, nutrition psychosocial support must be integrated into treatment plans. Why do we need this shorter regimen such as BPAL and BPAL-N? Shorter treatment regimens such as BPAL and BPAL-M are very essential and then transformative. They provided over 90% effectiveness, significantly reduced treatment duration, and minimize pill burden and side effect. And additionally, they are more cost effective. And these advantages collectively reduce treatment fatigue, enhance adherence, and improve overall treatment success. I would like to share with you the Lift TB project, this Indonesian experience in implementing the BPAL regimen, and I happen to be the leader of this operational research. The implementation of regimen has demonstrated a high treatment success rate and also a favorable safety profile. Particularly when we use 600 milligram dose of linezolid, which had fewer adverse events and serious adverse events compared to the 1200 milligram dose. This result support broader implementation across the country. And here is our success story from Indonesia. The slide here showing the significant shifting from long-term regimen to 6-month regimen. I would like to say here, in the beginning of January 2024, we still use 63% of long-term regimen. But with the new 6-month regimen, there was a declining rate of using this long-term regimen, and we succeeded to only use 17% of this term regimen in December 2024. And let's have a look to the PAL regimen, the orange line here. We start with 15% in January 2024. But we see here the tremendous increasing usage of BPAL-M until 76% of the whole drug-resistant TB in Indonesia in December 2024. So this is really a big change, and we are very happy with the result because the success rate is almost 90%, which is a very higher compared to our success rate before, which was only 57%. And here the use of ninth regimen, we can see here we used to have 21% of one regimen in January 2024, and the use is also declining until only 4% in December 2024. And the use of BPAL, because we had not so many of pre-XDR cases, so it's stable from 2% at the beginning of the year 2024 and 12% at the end of the year. This is a really good achievement, and I'm so happy with this achievement of the Indonesian MOH. But this achievement is also with collaboration with community and also NGO, and yeah. The increasing utilization of this 6-month regimen, I think, is in line with the recent study using semi-structured interview with national TB program staff and also experts from third country project. A project the adoption of 6-month regimens such as BPAL-M is increasing as program move away from lengthy toxic therapy in favor of more effective and patient friendly option. And with this slide, I do hope that countries such India, the Philippines, and also China and other countries will shift their treatment regimen from long to short regimen, and BPAL-M and other 6 regimen is safe and very convenient to the patient. So as a summary of the current WHO recommendation for DRTB treatment, for rifampicin resistant and MDR-TB, BPAL-M is recommended for individual age over 14 years, while BDL-LFHC or bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine regimen is preferred for children of any age, as well as pregnant and breastfeeding women. For those categorized as pre-XDR-TB, BPAL remained the primary treatment option. And for quinoline sensitive DRTB, both the all oral 9 regimen and the modified 9-month regimen are viable alternative. Finally, individualized regimen are reserved for complex cases where standard options are not applicable. So, as conclusion, the updated regimen offers efficacy and safety profile. They are more patient-friendly and promote better return, improve treatment outcome. However, this advancement must be by effective and inclusive program implementation to fully realize their potential. I do hope that my presentation give you some insight. Thank you for your attention. With a collective commitment and innovative approach, we can move closer to ending TB. Invest, commit, and deliver. Thank you very much. Over to you, Dr. Sahu.
Thank you, Dr. Arlina. That was a very good summary of also the progress that has happened in drug-resistant TB. As you know, drug-resistant TB is not easy to diagnose and treat. Some years ago, this long-term regimen that Dr. Arlina mentioned was probably the only option, with people getting treated for 18 months. Quite complex regimen, a lot of side effects. But now it's great to see BPAL-M regimen, just 6 months, same as drug susceptible TB, duration-wise, like 6 months, for drugs similar to first-line treatment. So it is very simple, and it has dramatically changed, and you saw the treatment outcomes going up in Indonesia. And I must say that most countries who are now scaling up, it is going up. So please demand for this regimen. Please demand for the correct and the most modern treatment regimen wherever you are practicing. Countries are procuring these drugs. Also, the child-friendly formulations, they are procuring it. It's available. We know because Stop TB Partnership has a global drug facility from which these are available. So please try to access them. Now, before we go to the exciting panel, we have one more presentation, and I would request Srinivas to be brief because we are a bit behind time. So Dr. Srinivas is, he works in Stop TB Partnership. He is a medical doctor with a postgraduate degree in public health. He has 25 years, more than 25 years of experience in public health, mostly in TB. And he is senior advisor with Stop TB Partnership, and his expertise includes TB epidemiology, TB control strategies, policies, urban TB control, private sector engagement, public health interventions, and better lung health, operational and implementation research. So, Dr. Srinivas, the floor is yours.
Thank you. I hope you can hear me. Can you hear me?
Yes, sir. Yes, sir.
Okay, thank you. Thank you. I'll be discussing briefly about, some of those old and new interventions for tuberculosis prevention. So, Dr. Sahu, in his presentation, has mentioned about the flow of the tuberculosis from the normal to latently infected to the active diseases and the diagnosis and treatment. And I will briefly touch upon these two areas where a normal healthy person, how can we prevent from them getting latently infected, and also those who are latently infected, how can we prevent them to develop from active disease. And for the first part, an important component is airborne infection prevention control. Of course, we can, by reducing the tuberculosis load in the community, definitely we'll be able to reduce that infection in the community. There are some social factors, which is like the nutrition and vaccine in the future. Similarly, for those who are infected, and how we can prevent them from developing to active diseases. It's important to screen the contacts and give them TB preventive treatment. So I will discuss briefly among some of this. We know that tuberculosis is an airborne infection, and this is important to understand this droplet concept. These are the small droplets, and they are pretty small, and they live in the air for quite some time. And so first part, as we'll discuss about some of the airborne infection control strategies. And there are three areas we will discuss. One are the administrative controls, where you have the policies and practices to reduce the risk of exposure. It's basically by doing some simple intervention to reduce this airborne droplets in our settings. And then there are engineering controls, or environmental controls, which we can talk about to reduce the concentration of the infected bacilli in the air. That is also, and the third one is about how we can use personal protection, respiratory protection measures. All of them are much simpler. These are some of those examples. I think that as practitioners, as healthcare workers, if we give some extra efforts in this, it will really be quite useful. And these are simple measures like having a registration desk screening for cough. And we have seen during the COVID pandemic, some of this fast tracking has happened, but then we forgot about it once the pandemic is over. Masking at the registration desk, giving a simple mask to patients who are coughing, it can drastically reduce the generation of the droplets. And of course, there should be messages, posters, or communication material to the patients on cough hygiene and how to cough. These are, there's nothing new about it, but it's about giving some importance in looking at it and getting those practices done. These are also, again, some of the administrative measures like, cough-producing procedures that generate hospital aerosols in our hospitals, like bronchoscopy, suctioning, sputum induction, and other endoscopic procedures where it needs to be done in a separate, well-ventilated rooms, and being aware that these are procedures which can generate aerosols. These are, again, simple things like environmental controls, maximizing ventilation. And the best way to create a proper ventilated room is to keep our windows and doors open. And there need to be sufficient airflow exchanges, at least 12 airflow exchanges per hour. And what we need is that there need to be administrative procedures to keep them open. Mechanical ventilation like air conditioners are there, and they have is being used very well, but then they're not that great as far as airborne infection control is concerned, unless we can ensure that there is sufficient air exchanges happening. UV radiation, yes, these are good AIC measures. Sunlight is definitely the best, and if you can actually, a lot of these procedures, including sputum collection, if you can do it in the open air, and if there are sunlight available out there, probably that is the best. Upper air ultraviolet is good. However, we need to ensure that it is working all the time, there is electrical supply, and there is frequent cleaning of those tubes, and it need to be positioned at the right places. This is a simple one which for us to really look at it, and when you are looking in your clinics, in your hospitals, this is just, you see that there is a healthcare worker and there is a patient and there is wind flow, and if the wind flow is from the healthcare worker towards the patient and going out, this is good. But if you look at the reverse one is really bad, then the infection can come towards the healthcare worker. And these are, again, simple, commonsensical one, but that is sometimes absent. And maybe this is a good compromise where you keep this one. So just by positioning your rooms, you may be saving yourself. Exhaust fans are pretty good, and especially in those places where the doors and windows have to be kept closed, then these exhaust fans are very good. But the ceiling fans is only justifiable if there is a good airflow across the rooms. There are many, room air cleaners, and the efficacy of them as an AIC tool is questionable. But what if it is really there? It's okay, fine, you keep it, but don't be complacent about it. That will really make it, we suddenly get equipment there and they'll feel that we are all safe, but that is not true. So don't forget the first administrative and other measures before, and don't restrict yourself to only using these air cleaners. The mask is that we have, it's fun that is even after the COVID time, we still need to talk about the masks. But remember, the masks are for as a personal protective measure. It is only if you are using simple surgical mask. This is only decorative, and it's not really going to. These are too small. The aerosols are less than 5 micron in size, and they are very small, and they can go easily. And in no way this simple cotton mask can protect us. There is enough space there, but the respirators are the ones which we should be using as a personal protection measures. Mask can be given to the patients or anyone who is generating the aerosol. So that when at the time of generating the aerosol, they are very big. So this mask is good enough to protect it. But when it is in the aerosol, it is much tinier and it can infect us badly. Some of the do's and don'ts on the respirators, it is basically need to be properly fitted. That's the main point I wanted to share, that there is, whether it's the bridge of the nose or the chin, there should not be space. And finally, if you keep it like this, it is as good as keeping the condom in the pocket. It's not going to do the job, right? So wearing the mask is important, and wearing it is at all the right time is important. And it is not the mask, it is the respirators which we need to use it. Now I will go into the next level, which we have talked about the TPT and some social factors like addressing the nutrition, which Sahu has mentioned earlier, and a little bit about vaccines. TB infection, there is a lot of confusion between TB infection. I have also seen some of the chats. TB infection is the first stage where the bacteria gets infected into us, and we develop some immunological reactions which we can identify them. TB infection doesn't mean that TB disease. TB infection typically doesn't cause any symptoms. So while we are into this, trying to find people with tuberculosis, we will identify there are some presumptive TB cases, and they need to be tested for TB, as we discussed earlier. If the TB is confirmed, then they can be given, they should be given treatment. But if there are no TB, then we need to assess them for TB preventive treatment and give TB preventive treatment. So giving TB preventive treatment for infected people have been very, very effective. And that is the vaccine which we have for TB currently. And if there are no TB, again, test for TB infection in high-risk group of people, which we will come up later, and then assess them for TPT. Then we need to rule out tuberculosis in them and then give TB preventive treatment. Who to prioritize? Yes, the people living with HIV and child contacts, WHO clearly give this as a two highest priority groups, because once these are the chance of them getting infected in tuberculosis is high, and if they're getting infected, the chance of them breaking down is also very high. Giving TB preventive treatment among these groups have shown very high efficiency, even up to 90% of prevention of tuberculosis. Adult contacts are another groups. Again, contacts means you are in the household, you are close to the patient, and there is a high chance of you getting the infection. And in those people, we need to test for TB infection and then provide TB infection treatment. There are other clinical risk group patients with immunocompromised conditions, people receiving TNF-alpha treatment, or they're ready for renal transplant. In such patients, these are clinically high-risk groups. It's always good to do a TB infection test, and if the TB infection test is positive, treat them with the TB preventive treatment. In the programmatic settings, there are also recommendations for systematic screening, LTBI testing and treatment for groups like prisoners, health workers, immigrants from countries with high TB burden, homeless people, and the people who use drugs. These are conditional recommendations. This is based on the country, the individual program policies, but these are good practices. An important area which we should be doing, and every time we come across a patients with tuberculosis, you diagnose a patient with tuberculosis, is to take an extra effort to do contact tracing. Their family members need to be screened. And if they have, especially children under 5 years, they need to be put on TB preventive treatment. And if adults, we need to test their infection, test first for TB, and if they don't have TB, test for TB infection and give TB preventive treatment. These are very effective. And there were doubts about, there were questions about whether the giving TB preventive treatment is causing drug resistance. No, when we are talking about TB infection, it just means that there is no. It also means that there is no active TB. There are many studies which shows that giving TB preventive treatment is not creating drug resistance. TB infection testing, there are many tests. The classical TB TST using PPD, that is the Mentos test. We all know that's a traditional method of detecting TB infection, but its specificity and sensitivity is slightly lower. And now there are other tests. IGRA is, we know it's common, and these are the blood tests that measures the immune response to the bacteria. And then now there are newer tests like Mycobacterium tuberculosis antigen-based skin test. Both the IGRA and this antigen-based skin test, many of them are, they use the same Mycobacterium antigens like ESAT6 and CFP10, and they have got almost similar sensitivity and specificity. The treatment regimen for TB preventive treatment, the 6 to 9 months of daily isoniazid was the old treatment, and they have many studies have shown that they are quite effective. There are newer regimens. This is a big change which has happened. Instead of giving it for 6 or 9 months of treatment, 3 weeks of rifampicin and isoniazid, we call it 3HP treatment. It's the 12 weekly doses it is as good as giving the 6 months of isoniazid. There's also 1 month of rifampicin and isoniazid is another regimen which we can give, and there is of course isoniazid and rifampicin can be given for 3 months, and there is another 4 months regimen with rifampicin and all. These are all recommended, and we can provide it as the case may be in your particular situation. And for MDR TB and rifampicin-resistant TB, there is 6 months of daily levofloxacin is advised as a preventive treatment. As Sahu mentioned, I will not go into the detail. There is a compelling evidence for the role of nutrition for preventing tuberculosis. So it's both for a better treatment outcome of tuberculosis patient, as well as the contacts to prevent tuberculosis in their contacts, proper nutrition. And so at least we need to do a nutritional assessment and a nutritional advice. And if there are systems for nutritional supplementations to those patients or their contact or the family members, and that is great effort, that's great, and we should be going towards that one also. TB vaccine, there are many TB. Earlier, we didn't have much except the BCG, but now there are at least 15 vaccines in various stages of trials, and we have about 6 vaccines in phase 3 trials, and we hope that some of them will come soon. And when these vaccines are coming, we really need to have a stronger advocacy to ensure that these vaccines are accessible to the private sector, and also we should be championing for providing vaccines to the population. Thank you.
Thank you, Dr. Srinivas. So this was the prevention aspect of TB, because we will not end TB by just diagnosing and treating. Prevention part is also important. So thanks for giving an overview of that. Now we have covered the diagnosis, treatment, prevention. And now we will have a moderated panel discussion. And for that, I hand over back to Dr. Asokan. Dr. Asokan, you can decide whether we need a break or we can continue.
No.
No,
So I think everybody are very interested and they have been staying back. So far, I can tell you that we have received 1,500 filled up forms and from 10 countries. I think it has been a useful session. And right now, we'll be handing over the floor to the panelists. The panel will last for 40 minutes. And the panel is led by Dr. Jailal, the president of CMAAO. And the panel is about uh, uh, the coordination with the national program and the public health testimonials of the private healthcare providers. These panelists are from different locations. If the panelists can say hi after their introduction, then everybody can see them also. We have Dr. Raghuram Rao, who is from the Central TB Division, Ministry of Health and Family Welfare, Government of India. He has been with the National AIDS Control Program and as well as the TB Elimination Program. And he's leading the TB surveillance, epidemiology, policy planning, NextShy application, artificial intelligence, and digital intervention. Dr. Raghuram, just say hi if you are available.
Yeah. Hi, everybody. Yeah.
Yeah. We have Dr. Jeremiah Chakaya, who has been a leader in tuberculosis control throughout his career in his home country of Kenya. And he also acts as the technical advisor and director of the Kenya Association Against TB and Lung Diseases. Dr. Chakaya, are you available? Just say hi, sir. Dr.
Hi.
Chakaya? Yeah. We are not seeing you. Let us, yes.
Where is me?
Hi, sir. Hi, sir. We have Dr. Joy Karamana Mugambi, who is a family physician from Kenya. She is the Secretary General of Commonwealth Medical Association and the chair of the Kenya Association of Family Physicians. Dr. Joy, I'm sure you are available. Just say hi.
Hi, everyone.
Yeah, that's great. We have from Indonesia, Dr. Kolanda Maria Septoli, who is a pulmonologist and is practicing in RSU and RSUD hospitals in West Java. Dr. Kolanda Maria Septoli, hope you are there. Just say hi.
Hi, everyone.
Thank you. We then have Dr. Julie Christie Visparas from Philippines, and she teaches physiology and cardiopulmonary modules as an assistant professor in University of Santo Tomas, and she's the chief of the section of pulmonary medicine in Department of Medicine UST facility on medicine and surgery. She's from Philippines. Dr. Visparas, kindly say hi. She available?
Hi, yes.
Yes,
Hello.
very much, very much. Then we have Global Fund Advisor from Geneva, Dr. Mohammed Yassin. Dr. Mohammed Yassin is the chair of the Global Public-Private Partnership Core Working Group of the Stop TB Partnership, and he is the Senior TB Advisor at the Global Fund. Dr. Mohammed Yassin, kindly say hi so that everyone can see you.
Hello, everyone. Thank you.
So, Dr. Jailal, kindly take over.
Thank you, Dr. Asokan sir, for introducing the panelists, and they are the very vibrant people. Friends, and all the last 2 hours, we have seen and heard the way how the science has progressed in diagnosing and various options of the treatment available. So far in the history of the tuberculosis management, the main role is played by the public health or the government sector. The government is what is deciding, and government is what is procuring the things and formulating the things and doing. But actually, when you're looking into the various countries, the amount of the private participants, the private practitioners, private firms, private research forums, and their contribution into the healthcare, or especially in the TB control, is phenomenal. And now there was always, it is like a parallel road they were going on. But a lot of efforts is put by the Stop TB division, where that this too has to join hands together and hold their hands very firmly and mutually support each other and reciprocate their work together, so that we need to achieve the goals of NTB by 2030. From that mission of reaching out, that the joining together the government sector, public health, and the private practitioners together is the main theme of bringing together national medical associations into the fold of the Stop TB Alliance and bringing the new constituency, the private practitioners constituency. So now this webinar is being mainly organized. We have very limited to the government side people. We have a very National Medical Association practitioners bringing together, because just to interpret and understand what is the basic difference we have as a private practitioners, and what kind of difficulty, especially in terms of utilizing the government-sponsored diagnostic facility, getting the free drug supply, or getting the reporting, the notification of the diseases, the nutritional support to the people, and reporting on the outcome of our diseases, how we are going to do. And this each differs from each country. But we know now we have now speakers from the high burden countries, and they are going to tell us and what is their experience in their country, and how the private practitioners are contributing to the development of the strategic goal, and what else they can suggest, promote, so that this forum, this big body, we are a very powerful now alliance, and this and the major sponsors and how best we can, all are very experts. They can speak for hours, but unfortunately we have a very limited time. So in the first round, and each one of is going to tell them about the perspective of the country and perspective of the region they belong and what they are doing. It is my honor to now invite Dr. Zakaria. Zakaria, who is one of the very, very renowned tuberculosis person, not only from Kenya, but for entire world. He has worked with the WHO, he has worked with so much of contribution. So, sir, in your understanding, in your perspective, as a whole of African region, not pertaining to Kenya, and what do you feel, and how is the status of private practitioners' participation, and what is the challenge, and what do you want to tell us, sir? Dr. Chakaya? Are we having Dr. Chakaya was here?
Please unmute Dr. Chakaya.
Yeah, I think he is not able to unmute. That is what he is here.
Okay.
Yeah, now.
I hope you can hear me now.
Very well, very well. Yeah.
Well, thank you, first of all, for the invitation to be part of this panel. I really want to appreciate the organizers for asking me to be part of this panel. In Africa in general, healthcare provision is shared almost 50% between public sector and the private sector. You have to consider the private sector is very large, is very heterogeneous in the African setting, and it includes facilities that are owned by faith-based organizations and national and international NGOs, and also what you would consider private for-profit healthcare facilities. Just to give you an example, in my own country, 48% of health services in this country, Kenya, are provided by the private sector as described. So the private sector is a major player in health service provision, and therefore it should also be a major player in the provision of health services, of TB services. Unfortunately, that situation doesn't always pan out as well as we would want it to pan out, and coverage of PPM or private health facilities not as smart or as good as it should be. In my own country, for example, only a small proportion of private healthcare facilities are currently engaged. And this is not a phenomenon that I would believe is only peculiar to Kenya or to Africa. I think it's a global thing, that coverage of the private sector by, the coverage of private providers for the provision of TB services is not as good as it should be. However, there's a lot of efforts that are being done across Africa to try and see coverage is improved. And because of the problems of inadequate resources for PPM in Africa, I see a lot of effort being done to prioritize which providers to engage and to try and come up with engagement processes that are appropriate for the cadres of healthcare providers that are in the private sector. I think there for now. Thank you very much.
Thank you very much, sir. Thank you for putting forward your view, and we will come back for some questions to you in the next round also. Now I will invite from Indonesia, Dr. Kolanda. Indonesia is, we all know, one of the second largest country having the tuberculosis population, and the incidence is almost, it is quite high, but the incidence is there. A lot of efforts are put forward to control with the role of private practice also. We will hear from Dr. Kolanda how the private practitioners are contributing in this TB control, and what are the challenges and how best that we can overcome them. Dr. Kolanda.
Okay. I think I have a good experience in TB service in our private practice because the government and hospitals are very supportive and facilitate tuberculosis service in our country. Our Minister of Health regularly have a coaching to our hospital, and even still many limitation, like sometimes our toolkits in examination such as cartridge for PCR TB is empty, but this can be overcome by working together with primary healthcare and government hospital.
Okay, thank you for your input. Now I will invite one of the very important person from India, Dr. Raghuram. He is directly a Deputy Director of Tuberculosis Control Program of India. But India is one country of among all our what we are talking about, the 25% of the tuberculosis population is with us. I mean, that is 1/4 of the world. The tuberculosis population is in India. A lot of efforts are put in forward, because in India is one country where it is more than 50% is by the private practitioners, and we hear now a lot of reporting decrease in the mortality. But what best, still a lot of things to be done. We will hear from Dr. Raghuram. And what is your perspective on these private practitioners and the challenges of the tuberculosis control, and what we can do best more? Over to Dr. Raghuram.
Yeah, thank you, sir, and thanks to everybody, the organizers, for having me here. India, like you rightly said, a huge burden that we have here, and our population's health-seeking behavior is such that half of the population, almost, I would say 60-70% for them, the first referral point is always the private sector. And our estimates say that almost half of the number of the cases are seeking care in the private sector. Now, when I say that, we had almost, over a decade and a half interventions on private sector that has built up, learned from its, implementation over the years. And now we have a seasoned mechanism by which the private sector and the public sector jointly work towards addressing tuberculosis. TB in India has been made a notifiable disease, which means that it's mandatory for the healthcare providers, the chemists, pharmacists, the laboratories to notify the case. So that's the first step that we need to do, is make it notifiable. And then it's not just creating rules or acts, but also creating that enabling environment that is required to help the practitioners notify the cases. So the IT portal that was created, and we put in systems wherein either the public sector peripheral health worker or an NGO, an interface agency worker reaches out to the private practitioner, helps them notify the case, manages the public health actions for those cases, extends the free drugs and diagnostics to the cases that are seeking care in the private sector, all those things. So it took us a while to build on our experience. And in 2015, if I were to give some numbers, we had around 100,000 cases that were notified from the private sector. And in 24, this year, we had almost a million, 9,500, 950,000 cases that have been notified from the private sector. Overall, of the total notifications we had in the country, almost 37% of the notifications came from the private sector. And which means that very clearly it can work. If we join hands and if we have the right environment to help the private sector and the public sector to work together, it does show results. And we have multiple models that have been implemented in the country, and we were able to see the results of that. Also, apart from just mandatory notification, the government also gives incentives to the private provider for notifying a case, and not just notification but also reporting treatment outcomes. So two different incentives at two different time points is given to the private providers, and that helps. It's not just a stick approach, but a carrot and stick approach that is deployed, which helps us get all those things. Plus the free drugs and the diagnostics that are given are extended to the patients for based on their choice, of course. That helps reduce out-of-pocket expenditure, reduces a lot of cost that is involved in admissions or in diagnostics that happen in the private sector. So there is saving out there. Plus there are schemes in the government wherein for every patient for nutrition support, the government provides 1,000 rupees as a direct benefit transfer to the patient. So that is again available for all patients in the private sector also. And plus in-kind nutrition also is given by by our community support initiative called the Nikshay Mitra initiative. So there are multiple efforts that we had gone, and it's a full throttle in terms of the efforts, in terms of creating the enabling environment, giving incentives, providing the additional support to the private sector for the public health actions that is required, and the extending the free drugs, diagnostics, and nutritional support and incentives to the private sector patients. So I think it's a full basket of choices and interventions that we have done it and resultant we have over 8 times increase in the notification of cases that we are able to get from the private sector. So I think I wanted to share that in this forum. Thanks.
Thank you very much. So thank you for sharing. The marriage between the government and the private sectors are now running well, and we are hopefully we will get a positive result very soon. Yes, a lot of hiccups will be there, but that can be definitely overcome. Now, again, going back to African region, and we have in our midst Dr. Joy Mogambi. He is not only representing Kenya, but also the entire Commonwealth countries. And she has been vice president of the entire African region. So she knows widespread information about that. Specifically from Kenya, and as a family physicians, we know it is not that pulmonologists, it is not that the super specialist doctors are the first person to see the tuberculosis. It is the main role as a general practitioner, and the family physician is going to play a major role. And what is your perspective as a family physician, how you are going to contribute and how your country is doing with the private practitioners' contribution in the our mission of NTB care by 2030?
Thank you very much, Professor Jailal. And it's an honor to be here discussing this very pertinent topic. Yes, TB is ravaging us. It's one thing that we need to learn as professionals. And one thing that we have done within the professional organizations is ensure that we are building capacity. CMEs like this. We realized that most of the learning platforms are done during the day within the practices, but most of the people in private sector are not available during the day. So we changed the model of trying to teach in terms of capacity building around TB and the changes that are happening to the evenings to ensure that our members within the organizations and also those in private sector are able to get capacity built and are able to get the new treatment models, the new diagnostic models for TB, and ensure that they capture them early. We've got platforms where we engage the private sector and have them within WhatsApp groups for quick diagnostic discussions to ensure that we catch them up as early as possible. But we also are working as governments. I work within a devolved function of the government, and within that devolved function, we also are engaging the private sector, supporting them to ensure that their diagnostic tools are up to date. And also where they do not have, we have mobile transfer of samples between facilities and the hubs that we have as public sector. So supporting them as much as possible within their facilities is one thing that we have done. And around policy development and guidelines cascade is another thing we are doing within the associations to ensure that we catch up the private sector, and we also catch up our members who are even in public sector to ensure that they align with the national guidelines and the strategy that is set out. Thank you very much, Prof, and back to you.
Thank you, Joy, for sharing your views on that. And I think it is definitely a great information which you are giving. Now we are going to hear from Philippines and what is the status of the Philippines, the private practitioners, and the how they are getting involved in the NDP schemes, the notification, the getting the extra benefit and the nutritional support and the pharmaceutical support from the government for doing to the private people. And I think the Philippines is also doing extremely well in TB control, and a lot of efforts are being done. Over to Dr. Julie. We want to hear from you. What is the status in Philippines?
Yeah, good evening, everyone. So in the Philippines, we have the integrated tuberculosis information system, for which the notification of those suspected of tuberculosis and as well as those already pathologically confirmed are being reported by the private sector as well, because that's the gap in which the government has provided the means by which we could be able to participate in being able to give the numbers also, for which I think it's around 30% that the numbers in the private sector are handling for tuberculosis. It being a disease with a lot of it's a very important disease, and a lot of resources are needed, no? And so we need the government as well. And so we just coordinate most of the time our patients to the government sector to be able to, or the public sector, to be able to have the means to have the diagnostics for free and also the treatment for free. Challenges will be when the treatment or the medications are not very or there is a shortage of the medications, which has happened I think time and again, no, in our country because of the decrease in the support, no, from different agencies. And so the private sector and also the some of the other sectors are there to be able to augment this. Another challenge is to be able to give education to these patients so that they will be able to complete the medications and have the proper diagnostics. Being a geographically situated country like the Philippines, which has 7,100 islands, it becomes a challenge for us to be able to give the diagnostics. We only have around 350 or 360 gene experts in the public sector. And so the private hospitals are there to be able to provide the other means for diagnostics as well as medication, although it's going to be too costly for the patient. And so we, as a wrap up, we work hand in hand still with the government sector, with the public sector, to be able to reach as much patients as possible and be able to stop tuberculosis. Thank you.
Thank you very much. And over to Dr. Chakaya, sir, from African region. But you will see that Africa, especially the Central Africa, Namibia, and Nigeria, are the highest reporting cases, with more than 300 from 1 lakh case they are reporting. In the recent past, we see there is a drastic improvement in reporting from South Africa, and Nigeria has done a very good impact on report. Can you tell what is the reason for that good show from the Nigeria and South Africa we are getting? My second question will be that today we are in an era of the medical students and the junior doctors, and thousands of junior doctors are also seeing this webinar. What is your advice you are giving as an expert for the young doctors in the menace of tackling the tuberculosis in the future? Sir, please unmute yourself, Chakaya. I think you are muted.
Yes, I'm unmuted now. I'm sorry about it. Yeah, I mean, I think the driver of the good performance that we are seeing in several African countries, as far as PPM reporting, or rather reporting of people with TB from the private sector is concerned, is dependent on several things. One of those is the fact that PPM has become an integral part of national strategic plans of most, if not all, African countries. Because PPM is part and parcel of national strategic planning, there are targets that have been set, and these countries are trying very hard to set those targets. For example, in my country, we have set a target of at least 35% of all people notified with TB being notified by private providers. So target setting is extremely important. And I think the third thing is that the capacity has been built in many of these countries to be able to engage with the private sector. That capacity has been built in many ways, and to be honest, maybe over a period of time. So through training, through mentorship and supervisory activities, there's a good capacity for engagement of the private sector. But at the end of the day, one of the most important things that drives these things is funding. And I would want to thank the Global Fund and previously USAID. I don't know whether we are allowed to call it USAID, but they have provided critical funding over the years to support private sector engagement. And that's really, really moved things across many African countries, including my own African countries. So I think those are some of the elements that have helped to improve performance of the private sector for TB case finding and notification. I think going forward, for young medical practitioners getting into clinical practice, I think it's really important for people to understand that, one, we've just been told today how to diagnose TB and how to treat TB and so on and so forth. And as a good clinician, you want to be the best you can be to that individual and their family when they have come to you. You don't want to miss TB. And TB is such an important disease in the continent that I think in the practice of medicine, if you do not know how to practice, how to diagnose TB or how to treat TB, you are deficient. So I think medical practitioners in the continent of Africa need to how to suspect TB, how to screen for TB, how to test for TB, and how to treat TB. And I think it's also important that at the end of the day, when you treat people very well, your practice grows. And this is a very basic thing. So if you treat people with TB, treat them well, they will bring in many, many additional people who are sick from their communities to come and see you. So I think there are benefits for the practitioner and there are benefits for the public healthcare system with private sector engagement. Thank you.
Thank you very much, sir. I was waiting for this. That you are asking for fund, and unless there is the money is there, and it is not possible. And from where to get the money? And somebody should give, or we should raise our resource. So we have the best person to talk on that. That is from the Global Fund, who has a rich experience in being with the Global Fund and distributing. We know there is a lot of hiccups are now developed with the US funding is coming down. 75% of the global the financing is coming from the Global Fund. To the tuberculosis control. So Dr. Mohammed Azin is going to tell us, and in this changing scenario, and how he will be able to help us in building the fund for building a robust system of controlling TB. Dr. Mohammed, yes, please.
Thank you, Prof. Thank you very much for Stop TB and organizers for inviting me on this very important webinar. We need funding, and we acknowledge that we need new tools, innovations, and so on. But people should access those innovations and tools wherever they access service. And that's why it's very important that those opportunities are there. That Global Fund is a major source of international funding for TB, supporting for over 75% of international funding. While we also acknowledge that countries are actually funding most of the TB response, especially countries which are already represented here. We need to continue on that, and we need more resources. But I just want to highlight some of the opportunities and experience and examples we have seen as part of the Global Fund, especially in promoting private sector engagement in TB response. And in countries where most of the TB patients first go to private sector. This includes engaging the practitioners, also engaging the associations, the professional associations. And then we have been tracking overall the Global Fund investment in 11 high burden countries, which account to 70% of the TB burden, including India, Indonesia, Kenya, Philippines, Nigeria, and Pakistan. And all those high burden countries, and looking at how much are we actually investing, supporting as part of the Global Fund grant for private sector engagement component. That engagement including access to deployment of some of the molecular diagnostics tests, access to treatment and prevention as well along the cascade of care. And then overall the contribution to TB notification from private sector. And we have seen some disconnect. While there is a very good trend towards increasing funding availability for private sector engagement, including creating a new implementers who receive funding directly from Global Fund, including like from Nigeria. Thanks, Dr. Chakaya, for highlighting that already contributed a lot. We created a new private sector PR, principal recipient, which received money from Global Fund and engaged many more private providers, including pharmacies, which contributed to increasing TB notification, including in Pakistan, like the Mercy Corps is one of our implementers. So those are some of the examples. We have seen an improvement in overall funding available for private sector engagement to scale up innovations. But that also contributing to increasing proportion of notification coming from private sector. Some of the countries implementing a scaling up innovative interventions. Very good example from India, where the Global Fund funding contributed to scale up of innovative private sector engagement with intermediary agencies, which were implemented through the so-called JIT program. And then over 100 districts, that was expanded and transitioned to domestic funding. And we have been working closely with Dr. Rao and the team to make sure that those innovative interventions will continue when we transition those. And those are some of the examples. In Philippines and in Indonesia, we've been supporting professional associations and the private sector engagement, including improving access through providing vouchers to patients and including them in private providers in the sample transportation and facilitating payment of insurance and so on. These are some of the examples of innovative approach which Global Fund has been supporting, and we have the so-called catalytic investment, that's the matching funding, in addition to allocation to promote engagement of private sector and expansion of those innovative approach, including South-to-South learning, and we see that already contributing to notification. And we believe that investment in private sector engagement is cost-effective, should be expanded further, and there are innovative approach, and there are good reasons to engage everyone. Global Fund is a unique public-private partnership itself, and we work closely with the government, with the private, public, and the communities as well. That's how we can all end TB. As we heard that TB doesn't really recognize border, and everyone should be participated. And that we need to continue promoting. And the PPM core group, which I chair, is part of the Stop TB and promoting those engagements. And we are hoping that everyone who is involved in diagnosing and treating TB should be engaged in reporting as well. And that engagement should be with all accountability and equal partnership. That's what we would advocate in the future as well if we are going to end TB. Thank you. Over.
Thank you very much. And we are coming almost to the close of it within 5 minutes with a quick question. We are going to close. Dr. Kolanda, from Indonesia point of view, the National Medical Association of the Indonesia, how much they are useful, how priority they are giving to tuberculosis. They have a lot of work to do. But what is the priority of the National Medical Association of Indonesia on the tuberculosis and your perspective? Dr. Kolanda? You are here?
Yes, I'm here.
Yeah.
Okay.
What?
Our government is so helpful to supporting us to have a good service in TB patient. We have regularly have a meeting with the Minister of Health to get coaching and evaluation about the successful of the TB program in our hospital, and also supporting if we have obstacles in our service. And also we have a collaboration with the many professional organization to support us educating many peoples in our country. And I think our government is so helpful to our hospitals to get a good result in TB patient.
Thank you. Over to Joy. Joy, you are a family physician. I know that one of the greatest problems when we face tuberculosis is the stigma, the social stigma they have. When a public servant or the government is going to give a drug or identifying them, the stigma is relatively high because they always need the advertisement or something. But as a family physician, what do you feel like a stigma? And another one word you have to say, I mean, what is the relationship of the HIV and TB in a private practice as a family physician you are having? You have only 1 minute to answer, Joy.
Thank you very much, Prof. I'll take that 1 minute. Yes, there is a high prevalence of stigma. Working in the rural areas, yes, we have a large population that really has not understood tuberculosis, but the government has made quite a great progress. In addition, by adding the community health promoters. And through the community health promoters who are known by the community, we have been able to train them, educate them, ensure that they can pass the messages without having that stigma within the community, and educate the community the need to be able to come out and get treated, and the need to be able to handle the clients who have TB in the community. Case example, I once had a multi-drug resistant TB who really had a lot of challenges within the community. The wife had left, but working with the community health promoters, we gathered a number of women who supported that household, ensured the gentleman was well fed, and their medication were done at his household without him having to face a lot of hardships. So these are the interventions we can do even as family health practitioners, and ensure that our patients are supported and patient-centered care is offered so that they are able to get through their treatment without any challenges. And confidentiality is also key, but also ensuring that we support them. Yes, HIV is there. We are currently working on integration, having had the issues of the phase out of USID program. But with integration, we are also ensuring that we maintain confidentiality and we support our clients. Thank you very much.
Thank
and
you.
Back to you, Prof.
Thank you. Thank you, Dr. Raghuram, sir. India is one country where the Prime Minister himself has started the Prime Minister Nutrition Yojana program, where there is a tuberculosis people are getting the food and their nutrition is taken care. A lot of organizations are adopting the patients. How do you feel and this role of nutritional support is helping in TB identification and eradication?
Yeah, thanks, Dr. Jailal. I think the support of the community that came forward as part of that initiative, which our Honorable Prime Minister triggered, was to come forward to adopt a patient and provide nutrition support as one of that, but psychosocial support and provide any other support that is required for the patient. And what we were able to see with that is almost all the patients who had consented, who said that they would require nutrition support, found somebody as an Akshay Mitra and they came forward and they could do it. And we could see a difference of almost 3 times in treatment outcomes. Those who got a nutrition support as against those who did not get. Very clearly in India, nutrition not just has an impact on new cases, but also has an impact on making sure that we have a successful outcome and it helps in reducing mortality. So this initiative, I think, is something which we have now decided to expand to not just the patient, but also to the household contacts of the patient so that they do not become TB again. So that's something that we are looking forward to and expanding that. But that's a very good example of how without the government need to putting in their own resources, but the community comes together from their own resources, comes forward and adopts patients and takes the patient and walks with the patient towards a treatment, successful treatment outcome for them. Yeah.
Thank you very much. The final question to Julie. And Julie, we know that as a private practitioner, it is not only the curative part, now the nutrition we are giving. And Dr. Raghuram also said the contact tracing. And how much this your organ Philippines, you are able to do the contact tracing. And if the one patient is found positive, how much number of people you are screening and how you are going to do that in that country?
Yeah, so in patients who are especially bacteriologically confirmed patients, we actually have all household contacts living with the patient to have at least a chest radiograph done. And if they are symptomatic, we go to the route of being able to do the diagnostics screening also for the tuberculosis activity. With regards to the numbers, I'm not really sure if there is a data already, but most of the time in our practice, those patients being seen by the pediatrician are being referred to the adult pulmonologist also for their parents. And so they're able to have adequate contact tracing for those who are bacteriologically confirmed. In adult patients as well, if they are positive, those who are living with them are also having some contact tracing, but not all. So unfortunately, not everyone is being subjected to that because of, still education in the part of the other community or the household members. Back to you.
Thank you very much. And with this, we are going to wind up our panel discussion. We have heard from the experts and what is the various situation happening place. And it is one thing is very sure, unless we all join hands together and make that commitment and that passion that in our lifetime, and we should see the reduction. 2030 is a reachable time for all of us to look and see. And if we can all put our hand together, whether it is a private practitioner, government, Stop TB agents, or NGOs, and I'm sure and I'm confident that we will be able to reach out to the goal of ensuring the 90% reduction in the mortality and in the incidence of the tuberculosis patient. So thanks a lot for this panel, and thanks to all my panelists for your expert participation and being with time. Sorry for exceeding 5 minutes, but over to our the main chief moderator.
Yeah, thank you, Dr. Jalal, for that. Yes, we can eliminate TB in our lifetime. It's an ancient disease. It's a scourge, and with so much of effort, the Stop TB partnership as well as the global TB program, we should be able to do it. Dr. Agram had very clearly said the role of nutrition. The take-home message that I would like to add to that is nutrition has been found to be as effective as the vaccine. So I think this is something which we already have. Let the vaccines come. They may be actually complementary. But now take home this message that nutrition is all the more important even in prevention. Today our webinar has been a great success. 1700 plus doctors have attended this. Most all of them stayed back until the very penultimate moments. And the quality of the discussions were very high, and it has been appreciated in the chat boxes. When we discussed about this program, we were having the young doctors in mind. I understand that it has been a success. Our message is also that professional associations across the countries have a role with the government, advocacy with the government, and also with their members. It is possible that the clinicians should be brought in again in TB care and control. It is very important because stigma and confidentiality are the two factors which are driving the patient to the private sector. The private clinicians should be able to retain this, hold on the patients, provide services, and also advocate for their patients with their government. We need more and more advocates for the TB patient, and we need more TB warriors. From this group of doctors who have attended this CME, if we get handful of advocates to fight for tuberculosis as warriors, we'll be very happy from the private sector provider constituency of the Stop TB partnership. I'm extremely grateful to the leader, Dr. Yerlina, the president of Commonwealth Medical Association, Dr. J. Jalal, president of Confederation of Medical Associations of Asia, Oceania, Maria Minerva, and a great team of inspiration from Stop TB Partnership, Dr. Sahu, Dr. Srinivas, and the coordinator for excellence, Jennifer. And there are two back officers of Yerlina as well as myself. All those team workers have worked very hard, disseminate the message to bring the doctors to this so that they get more information and the patients get a better care. Thank you all for joining. Thank you so much. We close the webinar now. Thank you so much.
Thank you.
Thank you.
Thank you. Bye-bye.